Hi, and welcome to Rad Onc Talks, a lecture series designed for students and residents of radiation oncology. My name is Rhea Kraft, and I am a radiation oncologist based in New Jersey. I am studying for my oral board exam, and I put together a slide deck with what I think are high-yield clinical pearls for each of the different disease sites that are tested in oral boards. And I thought it might be helpful if I created a talk. My goal is to put this all together in just one talk that kind of comprehensively goes through each of the 8 disease sites and maybe not quickly, but at least fairly thoroughly reviews the most important pearls that we need to know around the workup and management of every disease site that's tested on oral boards. We're going to go one by one through each of the 8 different sections that are tested on the ABR oral board exams. And within each section, we will talk about the most salient diseases that I think we need to know within each section. And again, we're going to focus on pearls around the workup and management of these disease sites and not get as much into the staging and the anatomy. It is impossible to cover everything, but hopefully this video can serve as a nice refresher, just going through the highlights of what we need to know so that you can have all this information at the top of your mind and easily recall it at the time of exams. It's going to be a long talk, but what I've tried to do is front load it with some of the disease sites that we see less often. For example, pediatrics, sarcoma, lymphoma, things like that are closer to the front of the talk, and then things that are more common I've tried to keep towards the end of the talk, like prostate, breast, and so on. So let's start with CNS and pediatrics. And in the ABR study guide, what they have listed is benign and malignant diseases of the central nervous system, neoplasms of the pediatric age group, as well as histiocytosis. So let's get into things. The most common primary CNS tumor in adults is glioma, and specifically high-grade gliomas tend to be more common in adults, whereas low-grade gliomas tend to be more common in pediatrics. Oftentimes, these patients will present with some type of neurological symptom, and we often get a head CT without contrast initially just to rule out a bleed. And that ultimately will lead to an MRI of the brain with and without contrast, and we can image the spine if we're concerned as well. And that will usually show a tumor in the brain. Now, acutely, we definitely want to manage their symptoms. So if they're having seizures, you need to give them antiepileptics. If there's significant edema associated, as long as we are not concerned for a CNS lymphoma, it's okay to give them steroids to help manage their edema and also start them on a PPI for GI prophylaxis. When a person has a newly diagnosed lesion in the brain, your differential is a primary CNS tumor as well as metastatic tumor. So it's not written on this slide, but if they don't have, any history of malignancy or something like that, it makes sense to get a CT chest, abdomen, pelvis just to make sure that you're not missing metastatic disease of some sort. But assuming that this is what's looking like a primary brain tumor, the key for management is going to be maximal safe resection, which means we're trying to remove as much brain tumor as possible without compromising the patient's independent function. So that means we spare eloquent areas, the brainstem, things that would compromise the patient's life and or independent function. So maximal safe resection is a key word in the management of gliomas. And once we do that maximal safe resection, we want to get a post-operative brain MRI with and without contrast very quickly, within 48 to 72 hours post-operatively. The reason for this is that blood products after surgery, when they mature, they can appear bright on MRI. And if we wait too long, then those bright blood products may look like residual tumor. So to best be able to kind of characterize whether or not the patient had a gross total resection, whether there's residual tumor after surgery, it's best to get that post-operative brain MRI within 24 to 48 hours ideally. And then these patients are going to need adjuvant radiation, sometimes with concurrent chemotherapy if they have a high-grade glioma. And so we want to get a brain MRI right before radiation starts. Radiation usually starts about a month post-operatively once they've had some time to heal. And so we want to get a pre-radiation brain MRI pretty quickly after surgery as well. within 3 to 5 weeks postoperatively. And then after we finish radiation, we also want to get a post-radiation brain MRI within about a month post-treatment. So gliomas, especially high-grade gliomas such as glioblastoma, we're imaging these patients very frequently, right? Right after surgery, then about a month after surgery, and then about a month after radiation as well. So these are, I think, some important pearls as far as workup for glioma. After maximal safe resection, these patients are usually going to be getting radiation about a month after treatment with or without concurrent chemotherapy. And after they complete the radiation, again, we get that 1 month post-treatment brain MRI, and we will probably be starting them on some type of adjuvant chemotherapy as well. So glioblastoma is a grade 4, high-grade glioma, and it's probably the most common primary CNS brain tumor that we see in adults. Glioblastoma is differentiated from other common gliomas that we see, including oligodendroglioma and astrocytoma, because glioblastoma is IDH wild type, and these other types of gliomas are IDH mutant. So when you get the pathology and they ask, what do you want to see on pathology? You want to see, the molecular features, and there's something known as the Heme criteria that historically were used to grade glioma just based on what it looks like under a microscope. But in the modern day, we use histologic features as well as molecular features. So if you are IDH mutant, by definition, you cannot be a glioblastoma. You have to be IDH wild type to be considered a glioblastoma. And then regardless of whatever histopathologic features, if you have a TERT promoter mutation, EGFR amplification, or chromosome 7 gain and 10 loss, that then puts you into the glioblastoma category. And glioblastoma is managed with radiation to a dose of 60 gray in 30 fractions, and it's given with concurrent temozolomide, 75 milligrams per meter squared, and this is given every day, Monday through Sunday during the days of radiation. And then we follow that chemoradiation with concurrent temozolomide with additional adjuvant chemotherapy, and we give more temozolomide at a different dosing for 12 cycles post-treatment. So in a nutshell, that's the management of glioblastoma. And remember, the dose is 60 gray in 30 fractions, and there's alternate dosing for poor performance status patients, but likely I think if this comes up, it's going to be a otherwise healthy patient. So 60 gray and 30 fractions would be the dose. The other types of gliomas are low-grade gliomas, and then the grade 3 gliomas, management is a little bit different based on if it's an oligodendroglioma or an astrocytoma. So low-grade gliomas, there can be an argument to observe them, knowing that they are at risk of recurrence and also progression. But especially if they have high-risk features, which are the Satan criteria. So size over 6 centimeters, age over 40, tumor crossing midline, astrocytoma histology, or presenting with neurological symptoms. These patients, especially with low-grade glioma, are at a higher risk for recurrence, and we typically treat them with radiation alone to a lower dose of 54 gray and 30 fractions. And if we do temozolomide, it's given concurrently and adjuvantly, or they can just get radiation and then adjuvant PCV. And then grade 3 tumors are managed a little bit differently depending on if it's oligodendroglioma or astrocytoma. And again, I think that the adjuvant chemotherapy, if you look at the data, there's some, I think, nebulousness, and technically you could probably use either temozolomide or PCV for either of them. But the way that I remember it, I think about PCV for grade 3 oligodendroglioma, so adjuvant PCV. And then for astrocytoma, I think about no concurrent chemotherapy, but then adjuvant temozolomide. So it's easy for me to remember because astrocytoma has a T in it, so they get temozolomide, and then the oligodendroglioma, the grade 3 oligodendroglioma patients get adjuvant PCV. For these grade 3 gliomas, remember, grade 3 is also considered high grade, so they're going to get a dose that's closer to 60 gray, 59.4 gray and 33 fractions. I don't think you would be wrong if you said 60 gray and 30 fractions either. Oligodendrogliomas are 1p19q co-deleted. And remember, they have that kind of fried egg appearance on histology. And then astrocytomas are, again, IDH mutant, just like oligodendrogliomas, but they do not have that 1p19q co-deletion. Some common mutations we see with them are ATRX loss, TP53 mutation, CDK, N2A or B wild type. So that's in a nutshell how we manage these things. I think GBM, they're going to get chemoradiation with temozolomide and then adjuvant chemo. Low-grade gliomas, typically radiation and then adjuvant PCV. Same with grade 3 oligodendrogliomas. And then grade 3 astrocytomas, there's data that they don't benefit from concurrent temozolomide, but they do benefit from adjuvant temozolomide. So I think the chemo regimens can be a little bit confusing. The radiation doses are easy because if it's high grade, so grade 3 or a grade 4 GBM, they're going to get 60 gray. That can be given at 1.8 or 2 gray per fraction. And then low-grade gliomas get just a slightly lower dose of 54 gray in 30 fractions. This slide just briefly reviews one way of planning radiation for glioblastoma versus low-grade glioma versus high-grade glioma. And remember, when we simulate these patients, they're going to be supine, chin neutral, using a 3-point aquaplast mask. And typically we use VMAT planning with daily IGRT, and we get a daily CBCT to make sure that they are lining up appropriately. So the way that the RTOG contours for GBM, they take the T1C and T2 flare MRIs postoperatively, and they contour the cavity as seen on T1C, as well as the extent of the T2 edema. And that, with a 1.5 to 2 centimeter margin, will be taken to 46 gray in 23 fractions. And then there will be a sequential boost to just the cavity as seen on a T1 post-contrast weighted MRI. And that will have an additional similar margin of 1.5 to 2 centimeters. And that will be taken to a total of 60 gray and 30 fractions. So there's 2 phases. There's 46 gray and 23 fractions. And then for the last 7 fractions, you're only treating the T1 post-contrast cavity with a margin. And the typical CTV margins are 1.5 to 2 centimeters. And then the PTV margins are 3 to 5 millimeters, depending on your department's practice. I think low-grade glioma and high-grade gliomas, I think it would be fair to say that your entire GTV would just be the post-operative cavity as seen on the T1C with the T2 flare, and then similar 1.5 to 2 centimeter CTV margin, similar 3 to 5 millimeter PTV margin. Now, this is just one way of doing it, and I don't think this would be wrong to say on the board exam. But keep in mind that there are places that will do it as a simultaneous integrated boost. There's other ways of doing this, but I think this is one correct answer. Meningiomas, you might see just radiographically. These are typically dural-based, homogeneously enhancing lesions with a dural tail. And you can kind of empirically diagnose these just based on radiographic criteria. And if typically small asymptomatic meningiomas are observed, and only if they start to grow or are associated with significant edema or become symptomatic, that is when we would actually manage them. And management can be definitive radiation or surgery, especially if they're very large, causing mass effect, surgery would be preferred. So definitive radiation can be done either just based on radiographic criteria, or these patients can be taken to surgery and they can get tailored adjuvant radiation. If they're taken to surgery, we grade meningiomas based on what they look like under a microscope. So traditionally, we just graded them based on the number of mitoses per high-powered field. So less than 4 is grade 1, 4 to 19 is grade 2, and then 20 or more is grade 3. But now we have some data that having a TERT promoter mutation or CDK N2A or B deletion also pushes meningioma into that grade 3 category. So for grade 3 meningiomas, adjuvant radiation is always recommended. For grade 2 meningiomas, adjuvant radiation is recommended if the patient has, good performance status and is expected to live a long time, especially if they have a subtotal resection. But if they are, maybe elderly, frail, poor functional status, we can make an argument to observe the grade 2. And then grade 1 observation is actually preferred. The only time that you would give adjuvant radiation for a grade 1 is maybe if they have residual disease, they're still symptomatic, something like that. But otherwise, grade 1 typically observe after surgery. Grade 2 usually give adjuvant radiation unless they're very frail. And then grade 3, we always think about adjuvant radiation because those are very aggressive. And although meningiomas are benign, the grade 3 behave almost malignant. As far as the dosing for radiation, meningiomas can be treated either with conventionally fractionated radiation or with stereotactic radiosurgery. So optional doses from a radiosurgery standpoint for grade 1 are 12 to 16 gray in 1 fraction, or 16 to 20 gray in 1 fraction for grade 2. Or you can use a 5 fraction approach where we treat somewhere between 25 to 30 gray in 5 fractions. Conventional fractionation is usually preferred for grade 3, and the conventional fractionation dosing for grade 3 is close to 60 to 66 gray, so 59.4 to 66 gray. Grade 2, we can do 54 to 60 gray, and then grade 1, we can do 50.4 to 54 gray. I think the dosing for meningioma is easy to remember. If you remember grade 1, 2, and 3, and remember 50.4, 54, 59.4. So these are 1.8 gray per fraction, and then the number of fractions is just 28 versus 30 versus 33 for grade 1, 2, and 3. The volumes are fairly straightforward too. So for conventional fractionation, you're just contouring the GTV, and then you're adding a 1 to 1.5 centimeter margin, especially along the dura, because you want to kind of include a little bit of the dural tail, and then adding the same 3 to 5 millimeter PTV. For SRS, we often don't add any CTV margin, and then there is a 0 to 2 millimeter PTV margin depending on what machine you're treating on. Acoustic neuroma, also known as vestibular schwannoma, is a benign growth as well. Similar to meningioma, it's a benign growth of Schwann cells along the vestibulocochlear or facial nerve, often presents with unilateral hearing loss, and it's graded via the Koos grading system. So grade 1 schwannomas are intracanalicular, like shown in the image. Grade 2 are kind of extending into the cerebellopontine angle, but not yet touching brain. Grade 3, they're now abutting your brain tissue. And then grade 4, they're actually displacing brain tissue, causing mass effect. These can be managed with surgery or with radiation. And if they're managed with radiation, there's options for SRS dosing, so 12 to 13 gray in a single fraction, 18 and 3, or 25 and 5. Brain metastases are, again, the most common intracranial tumor that we see in adults, even more common than a primary CNS tumor such as glioma. If we have brain metastases, again, understanding the systemic state of disease and what's present systemically is important. But, for board exams, I think most physicians at this point, if patients have especially a limited number of brain metastases, there's a strong preference for stereotactic radiosurgery because it's associated with improved cognitive outcomes. So for tumors that are less than 2 centimeters, we can use doses of 20 to 22 gray in a single fraction. You can go up to 24 gray, but I would not go more than 24 gray. For tumors that are 2 to 3 centimeters and greater than 3 centimeters, there is the RTOG 9005 study where these doses come from, 18 times 1 and then 15 times 1. But in practice, I've actually seen more evidence for fractionation as well. And once things start to look more than 2 centimeters, then I personally often favor fractionation. So something like 27 gray in 3 fractions or 30 gray in 5 fractions, just because that helps maximize your local control while also decreasing your risk of radionecrosis. So think about single fraction regimen for things less than 2 centimeters, and once they're more than 2 centimeters, you can either decrease the dose or you can fractionate. And keep in mind that if you are in the brainstem, your single fraction dose is going to be lower, so somewhere between probably 13 to 15 gray times 1, or the more safer thing to do if it's in the brainstem is to actually fractionate. For patients that have innumerable brain metastases, or for example, patients with small cell lung cancer that have a number of brain metastases, There are some options. So we can do hippocampal avoidant whole brain radiotherapy, where we do 30 gray and 10 fraction. You try to limit your hippocampus max to 16 gray and try to keep the 9 gray isodose line from encompassing your hippocampus. So that's the dose to 100% of the hippocampus is less than 9 gray. If they have lesions that are in the hippocampal avoidance zone, then just a 2D whole brain plan to 30 gray and 10 fraction is an option. And if they're very poor performance status, then best supportive care is also an option, where we just give things like steroids, anti-epileptics, manage pain, manage whatever symptoms. I won't read through this slide in entirety, but just for reference, these are some general dose constraints for CNS that you can keep in mind. I think the most important constraints to be aware of are the maximum tolerated doses for the brainstem and then your optic pathway. These are probably, the most high yield to know. So with conventional fractionation, the brainstem max dose per Quantec guidelines is 54 gray, and then the brainstem maximum dose for the optic nerve and chiasm is 55 gray. I think in reality, if you say a number anywhere between 54 to 56 gray, you will be in the realm of correct, and 55 is an easy number to remember for these maximum doses. But remember, your brainstem max with conventional fractionation is ideally less than 54 gray. Your optic pathway max is less than 55 gray. With single fraction SRS, the brainstem max is much lower. It's between 12.5 to 15 gray. Optic max is between 10 to 12 gray. I think for boards, it's always easier to just be more conservative. So for brainstem, I would say my single fraction max is 13 and my optic max is 10 gray. With 3 fraction regimens, you get more leeway. So it becomes closer to 20 to 21 gray for 3 fractions and then 25 gray for 5 fractions. For your normal brain constraint, these constraints are important for SRS. So a V12 gray less than 10 cc's if you're doing single fraction SRS is an important constraint to know. And then if you're doing 3 fractions or 5 fractions, it's a V20 gray less than 20 cc's. That's important to know. So V12 less than 10 cc for single fraction, V20 less than 20 cc's for multiple fractions. And then the lens, we start to worry about cataracts when the doses with conventional fractionation exceed 6 to 8 gray. So you want to try to keep your max less than 6 to 8 gray. And I think these are the most important constraints to know. We already went over the hippocampus dosing for hippocampal avoidance. That brings us to pediatrics. And I have 2 slides on pediatrics. I have pediatric CNS tumors and then the pediatric non-CNS tumors. So the general paradigm for the management of pediatric CNS tumors is, again, maximal safe resection, followed by radiation with or without chemotherapy, potentially followed by more chemotherapy. The one exception to this is germ cell tumors, where instead of maximal safe resection, if we're suspicious of germ cell tumor, remember we get certain labs like AFP, beta HCG, and LDH. And then these patients actually get chemotherapy first with radiation based on how they respond. So I think the 2 most common types of pediatric CNS tumors that we're likely to encounter on boards are medulloblastoma and ependymoma. So medulloblastoma is a very common posterior fossa tumor. Ependymoma often also occurs in the posterior fossa. And I think medulloblastoma is one of the most confusing because we have to risk stratify into average risk versus high risk. So what makes you high risk for medulloblastoma? If you are less than 3 years old, if you have a subtotal resection defined as over 1.5 cc's of residual tumor, or if you have metastatic disease, or if you have aggressive histology, so anaplastic or large cell histology. So these are easy things to remember, right? If you're less than 3 years, when you get radiation less than 3 years, that's a pretty bad thing for cognitive function. So being younger in this case is bad. So for medulloblastoma, being younger than 3 years is bad. Having, gross residual disease with a subtotal resection, that's bad. Having metastatic disease is bad, and having anaplastic or large cell histology is bad. So that makes you high risk. And then everything else is average risk. So if you're over 3 years old, if you have a gross total or near total resection, again, defined as less than or equal to 1.5 cc's of tumor if you're not metastatic and if you don't have anaplastic or large cell histology. So medulloblastoma is one of the pediatric CNS tumors that gets craniospinal irradiation. And you have to remember the dosing as well as the volumes. So the craniospinal doses are different for average versus high risk. It's 23.4 gray at 1.8 gray per fraction for average, and it's 36 gray for high risk. And then the boost volume, the doses are similar, so it's only a difference of 1 fraction or 1.8 gray. So it's 54 gray boost for average and 55.8 gray boost for high risk. What's more different than the dosing is the volume. So for average risk, the boost volume is actually just the involved field. For high risk, we boost the entire posterior fossa. Okay, so for average, you're only boosting the tumor bed or the involved field. For high risk, you're boosting the entire posterior fossa. So again, average risk medulloblastoma patient gets 23.4 gray CSI followed by an involved field boost up to 54 gray. And then high-risk patients get 36 gray CSI followed by a posterior fossa boost to 55.8 gray. And then if they have metastases, you can either boost the individual metastases to 45 to 50.4 gray based on the spinal cord tolerance, or you can, if they have diffuse metastases in the spine, you can just increase your CSI dose to 39.6 gray. So medulloblastoma is confusing because remember, you have to risk stratify and that will determine your dose as well as your volume. But the easy thing for all of these Peds CNS tumors, and in fact all pediatric tumors, is that the dosing is all at 1.8 gray per fraction. Sometimes we're doing 1.5 gray per fraction if we're doing like whole lung or whole abdomen radiation. But otherwise, for treating the primary, it's always 1.8 gray per fraction. So you can't go wrong if you say 1.8 gray per fraction for pediatrics. With medulloblastoma, once you have that dosing under control, the systemic therapy is concurrent vincristine, and then they get adjuvant cisplatin-based chemo up to 9 cycles. Ependymoma is different than medulloblastoma because we don't do CSI routinely. We only do CSI if they have metastases to the spine. And then the dose is 54 to 59.4 gray to the tumor bed. And the chemotherapy is a little more controversial with ependymoma as well, but it sometimes can be used to convert patients that had a subtotal resection to having a more extensive resection. Gliomas, if it's low-grade glioma, we actually observe until progression, even if they have subtotal resection. So if you get something like a pilocytic astrocytoma, you can just observe that even if there's gross residual until the patient progresses. If it's a high-grade glioma, it might be something like a diffuse intrinsic pontine glioma, which has a very, very poor prognosis, a median survival of about a year. And we try to treat that to 54 to 59.4 gray. These are often very challenging to resect because they are right at the brainstem. There's not good data for chemotherapy with these, so the management is just maximal safe resection followed by adjuvant radiation. And we try to get to 59.4 gray, but remember that brainstem max dose is 54 to 55 gray. So the part that's overlapping with the brainstem, we often have to limit dose to 54 gray. Craniopharyngioma, if these patients do have a gross total resection, we can observe, but surgery might be morbid. We might do adjuvant radiation, 54 gray and 30 fractions with conventional fractionation, or somewhere between 10 to 14 gray with a single fraction SRS. If we do conventionally fractionated radiation for craniopharyngioma, remember that these might become cystic and they might have that like crankcase oil fluid appearance. And that cyst can kind of reaccumulate with fluid during treatment. So you want to be getting weekly MRI to kind of evaluate that and make sure you don't need to replan if that fluid is reaccumulating. So that's craniopharyngioma, 54 gray and 30 fractions. That brings us to the germ cell tumors. Germ cell tumors, remember, are unique because they don't require surgery. We typically get a biopsy alone, and then we do chemo first. If they have residual, they can get surgery, or they can just get radiation alone. Or if they get surgery, then they get adjuvant radiation. So germinoma is unique because we actually give whole ventricular radiation for the germinomas. And then for the non-germinomatous germ cell tumors, we give CSI. So similar to medulloblastoma, we give CSI for the non-germinomatous germ cell tumors. So germinoma, it's chemotherapy. And for both of these, the chemo is typically something like carboplatin etoposide. And then we assess their response after 4 cycles of chemo. And then if they have a complete response for the germinoma, they get 18 gray whole ventricular radiation. If they have a partial response, they get 24 gray whole ventricular radiation. And then they get a 12 gray boost to the primary tumor. So they're getting a total of 30 to 36 gray. They're always getting a 12 gray boost, and the whole ventricular dose depends on if they had a complete or a partial response. If they are not a candidate for chemo for whatever reason, they're getting radiation alone, the dose is higher. So it's 25 gray whole ventricular radiation and then an additional 25 gray boost. So they go to 50 gray. But if they're getting chemotherapy, then the post-chemo dose is 30 to 36 gray. For the non-germinomatous germ cell tumors, again, it's carboetoposide first or ifosfamide and etoposide first. So chemo first, and then surgery if residual. And then the radiation is 36 gray craniospinal irradiation, so similar to your high-risk medulloblastoma, and then an 18 gray boost to the primary for a total of 54 gray. So more aggressive treatment and dose with the non-germinomatous germ cell tumors, 36 gray CSI, 54 gray total to the primary. And then we have the atypical teratoid rhabdoid tumors. So these are treated similarly to your medulloblastomas also, typically 50.4 gray to the primary, and we can consider adding CSI of 36 gray if they're over 3 years old. So again, these are not a comprehensive list of all the possible pediatric CNS tumors. There's a lot out there, but I tried to list some of the ones that I think are fairly high yield and there's a chance of these showing up. And again, most of the time it's maximal safe resection followed by radiation, and sometimes we give concurrent or adjuvant chemotherapy. The most important ones, if you're going to learn any of these, I think are medulloblastoma and ependymoma. Remember, medulloblastoma, they get CSI. Ependymoma, they just get involved field radiation. And then with the germ cell tumors, germinomas get whole ventricular radiation, but non-germinomatous germ cell tumors, they get CSI. Then we get to our pediatric non-CNS tumors. So we have a couple of sarcomas, rhabdomyosarcoma, Ewing sarcoma, and then we have Wilms tumor and neuroblastoma. And each of these has a fairly unique management paradigm. So just briefly, as far as workup, rhabdo, Ewing, and neuroblastoma are the 3 where we need to get bone marrow biopsy. And neuroblastoma, we actually need to get bilateral bone marrow biopsy. So remember the sarcomas, right? Rhabdomyosarcoma, Ewing sarcoma. These are soft tissue, often bony-based tumors. So they're, of course, going to get a bone marrow biopsy. And neuroblastoma is a very aggressive neuroendocrine tumor. So we need to give or get a bone marrow biopsy for neuroblastoma as well. The management of rhabdomyosarcoma is probably the most complicated, where we do surgery followed by chemotherapy, followed by radiation at week 13 for low or intermediate risk, or week 20 if they have high risk. And then they can get more chemotherapy after that. The chemotherapy regimen is VAC for rhabdo, which is vincristine, actinomycin D, cyclophosphamide. So they get VAC for 12 weeks after surgery. And then we hold the actinomycin D during their radiation. And remember, rhabdomyosarcoma has a very complicated risk stratification where we have the preoperative stage, the postoperative group, and it becomes very complicated. But as far as the dosing, I think if we just think about dosing, it's more straightforward. So patients that have a complete resection or a complete response that have embryonal histology, which remember is more favorable, they don't need any radiation. But then if patients have any amount of resection, even if they have a complete response, even if they have a complete resection, or even if they have some positive margin or something like that, but they're alveolar, they're going to need adjuvant radiation, and the dose is 36 gray. Or if they're embryonal and they have a positive margin, so a group 2 resection, they're going to need radiation, which is 36 gray. So alveolar is always going to get radiation, and even if they had the best possible outcome, which is a complete resection, complete response, they're going to get 36 gray. For patients that have node positive disease or bulky disease, they can go to 41.4 gray. For patients that have gross residual tumor, we need to treat that to a higher dose. So if it's less than 5 centimeters, it can be 50.4 gray. But if it's over 5 centimeters, it can be 59.4 gray. And then finally, orbital rhabdomyosarcoma is commonly tested because it falls into a low risk group. But these patients cannot really have a gross total resection. They're always going to be group 3. So these patients are always going to need 45 gray, even if they had a complete response to chemotherapy, because these patients can never have surgery up front because that would require enucleation. So your orbital rhabdomyosarcoma, if they have a complete response, even then they're going to go to 45 gray. And then if there's still residual at week 13 when you're starting radiation, you can boost that more to 50.4 to 54 gray. But at minimum, orbital rhabdo is going to get 45 gray. So those are the rhabdomyosarcoma doses. Ewing sarcoma follows a very similar paradigm, except they don't get upfront surgery. They actually get induction chemo with VDC-IE. And then at week 13, you look to see if they're going to get local therapy with surgery and or radiation. There's certain expendable bones where surgery is fine, but many times if it involves a critical bone like the hip or something like that, or if they would require amputation, then radiation is preferred at week 13. And the dose of radiation is 45 gray to a pre-chemo volume, and then 55.8 gray to a post-chemotherapy residual. And your margins are usually smaller than with adult sarcomas, so usually just 1 centimeter margin. But the pre-chemo volume for Ewing gets 45 gray, the post-chemo gets 55.8 gray. And the chemo regimen for Ewing is VDC-IE. So rhabdo and Ewing sarcoma are managed fairly similarly, where the only difference is rhabdo is surgery first, Ewing is chemo first. But they both get 12 weeks of chemo, and then we look to see if we do local therapy. For rhabdo at week 13, that's some type of adjuvant radiation. For Ewing, that is either surgery or radiation. And the doses, I think, are fairly similar between the two as well. Again, 1.8 gray per fraction. For Wilms tumor, these patients need to go for upfront radical nephrectomy and lymph node sampling. We do not biopsy Wilms tumor. Then they need to get radiation at day 10 to 14. So very immediate, urgent adjuvant radiation, day 10 to 14. And the dose is 10.8 gray and 6 fractions if we're doing flank radiation. So if they are favorable histology stage 3 to 4, or any stage with unfavorable histology. And then if they meet those SPAR criteria, so if there's spillage, peritoneal seeding, ascites, rupture, they're going to get whole abdomen radiation. And you should know the fields for flank versus whole abdomen radiation. The chemotherapy regimen that's given after radiation is usually DD4A. And then finally, we have neuroblastoma, which is very, very complicated as far as management. Radiation only gets involved in high-risk neuroblastoma. We first treat these with induction chemo, followed by surgery, and then there's a consolidation phase with chemo, tandem transplant, followed by radiation, and then they get maintenance immunotherapy after. The radiation dose for neuroblastoma is 21.6 gray in 12 fractions. One last pearl that applies to every site in pediatrics, no matter where you're treating. Whenever the vertebral bodies are going to be getting any amount of radiation dose, you want to make sure that the levels of those vertebral bodies that are getting radiation are homogeneously covered. So for example, if you're doing CSI, you want to make sure that all of the vertebral bodies are receiving a homogeneous dose, so a minimum dose of at least 18 gray, for instance. And the reason for this is that if the vertebral bodies are treated asymmetrically, then you'll have asymmetric growth of the bones, and that can result in scoliosis. So you want to make sure that the vertebral bodies are homogeneously covered with the same level of dose, depending on whatever disease site you're treating. So for example, CSI, you're going to a higher dose, so make sure they're getting at least 18 gray. Wilms, you're treating to a much lower dose, usually 10 gray, but your flank field will cross 1 centimeter across the contralateral vertebral body because, again, you want to make sure that those vertebral bodies are being covered to a homogeneous dose. The very last slide I have in the CNS and Peds section is on Langerhans cell histiocytosis, not because I've ever seen it, but only because it was listed in the ABR Oral Board Study Guide. I think the only thing that we need to know about Langerhans cell histiocytosis is that if they have bone deposits, low-dose radiation can be effective for these. These are basically proliferations of myeloid dendritic cells, and they can lead to these lytic bony lesions. So the low dose of radiation that we use is anywhere from 6 to 12 gray at 1.5 to 2 gray per fraction. So Langerhans cell histiocytosis, Langerhans low dose. So remember, it's a small dose of 6 to 12 gray. Langerhans low dose. I know we spent a lot of time on CNS and pediatrics, but that's because there's a lot to cover. Head, neck, and skin on the surface looks like it has a lot of different disease sites, but the principles of management of each of these are largely the same. So hopefully we can get through this a little bit quicker. As far as workup, make sure that you're getting a complete history and physical exam. In history, we ask about head neck symptoms like dysphagia, odynophagia, otalgia, cranial nerve deficits, pain, bleeding. And then physical, you definitely want to do a comprehensive head and neck exam, palpate for cervical lymphadenopathy, examine the oral cavity, perform fiber optic nasolaryngoscopy, especially if they have nasopharyngeal carcinoma or something in the skull base. You also want to get a full cranial nerve exam to examine for any cranial nerve deficits. As far as labs, CBC, CMP are your basic labs, and then especially for oropharynx, P16 or HPV DNA testing is important, and for nasopharynx, EBV DNA testing is important. Pathology for head and neck and FNA biopsy of any suspicious lymphadenopathy is actually completely fine, and ENT can also perform biopsy of a primary. And keep in mind that if you have a head and neck of unknown primary, then they need an exam under anesthesia with a direct laryngoscopy by ENT, and they often sample random biopsy samples, and they also do bilateral tonsillectomy. As far as imaging, CT neck with contrast and a CT chest at minimum, but oftentimes we end up getting an FDG PET CT, which is sort of the gold standard for squamous cell histologies, because that's really helpful for evaluating lymphadenopathy, ruling out metastases. And then anytime you're concerned about perineural invasion, also get that MRI. And then key evaluations that are needed for all head and neck patients: speech and swallow evaluation, nutrition assessment, dental assessment, because any teeth that need to be pulled out should ideally be pulled out before starting radiation, audiology, smoking cessation counseling. If patients are presenting with weight loss, consider a PEG tube placement up front, or we'd always, monitor their weekly weights and counsel them on the potential for needing a PEG tube if they have over 10% weight loss during treatment. Most disease sites within the head and neck can be managed either with surgery, followed by tailored adjuvant treatment that consists of either radiotherapy alone or adjuvant chemoradiation, or they can be managed by definitive radiation with the addition of concurrent chemotherapy in the definitive setting for more locally advanced disease, generally T3 to T4 disease or N2 positive disease. So the disease sites that are generally managed by surgery, where we really favor doing surgery, paranasal sinus, salivary glands, oral cavity, and then thyroid. I think these are the main disease sites where surgery is kind of recommended up front, followed by tailored adjuvant treatment. So thyroid, and then oral cavity, salivary glands, paranasal glands, the things that are more towards the outside of your head and neck, right? Sinus, nose, salivary glands, oral cavity. The nasopharynx is actually unique in that the recommendation is for chemoradiation rather than surgery because it's a very anatomically challenging site for surgery. So nasopharynx actually follows a unique paradigm where we do induction gemcitabine cisplatin for 3 cycles, especially if they have the keratinizing type 3 histology, the histology that tends to be seen in endemic populations such as China. So induction gemcitabine cisplatin for 3 cycles, then chemoradiation therapy. And nasopharynx is also the one disease site in head and neck where immune checkpoint inhibition has shown a benefit. So there's a trial for a drug known as carmalizumab, which is, I think, just your standard PD-1 blockade. And there's data for using immune checkpoint inhibition adjuvantly after chemoradiation for nasopharynx. Okay, so nasopharynx, definitive chemoradiation. We talked about the sites where surgery is favored up front. And then the other site where radiation is actually favored besides nasopharynx is the hypopharynx because, again, it's an anatomically challenging site for surgery. So hypopharynx, we generally favor definitive radiation with or without chemotherapy. And then finally, we have oropharynx and larynx. And these tend to be some of the most common sites that we see head and neck cancer. And for oropharynx and larynx, surgery and definitive radiotherapy are options, and it's always a multidisciplinary discussion with the patient. So for oropharyngeal cancer, you can certainly think about doing surgery followed by tailored adjuvant treatment, and there's ongoing studies for de-escalation of that adjuvant treatment for P16 positive patients. Or you can do definitive radiation if we think that they're going to need trimodality anyway. Larynx, same thing, surgery versus chemoradiation. For patients that have a functional larynx, meaning that they are protecting their airway, they're able to vocalize, oftentimes trying out chemoradiation for larynx preservation makes a lot of sense. So again, the disease sites within the head and neck are kind of heterogeneous in the sense that the general treatment paradigm can differ, the staging can differ, but the general radiation recommendations are very, very similar. So if patients are getting surgery up front, the indications for doing adjuvant radiation are typically if they have T3 to T4 disease, N2 to N3 disease, if they have extracapsular extension, close or positive surgical margins, LVSI, PNI. And usually patients that get surgery are going to have at least one of these risk factors that make us want to offer adjuvant radiation. The indications for adding adjuvant chemoradiation are if they have a positive margin or if they have extracapsular extension. So anything that would leave microscopic disease behind, you give chemotherapy as well in the adjuvant setting. For definitive radiation, the indication for concurrent chemotherapy is if they have T3 to T4 disease or if they have N2 or higher disease. The doses for radiation are very similar across all the disease sites. So let's start with the right-hand side of the slide, which is the postoperative radiation dose. If we're delivering postoperative radiation for one of the standard indications that are a high risk factor, the dose is typically 60 gray in 30 fractions, and we often deliver lower dose levels as a simultaneous integrated boost. So the full 60 gray goes to the tumor bed, that's 2 gray per fraction, but then we can do 57 gray to the operative bed and 54 gray to elective neck volumes. So 60 and 30 is the standard dose, and you can have lower elective levels at 57 and 54 gray. If we are adding concurrent chemotherapy, and remember that's if they have a positive margin or extracapsular extension, then we also are typically boosting the area of positive margin or ECE to a dose of 66 gray. So you treat everything as above, but then you add a sequential 6 gray in 3 fractions just to the area where you're concerned about a positive margin or where you're concerned about ECE. And if you can't fully localize the exact level that you need to treat, then you can, or the exact area that you need to treat for that ECE boost, then you can treat that entire level if you're concerned about a lot of matting of nodes within that level. So you can boost that entire level to 66 gray. Okay, so the postoperative radiation dose I think is easy. It's 60 gray in 30 fractions, boost to 66 if you're adding chemo, and you're adding chemo if they have a positive margin or extracapsular extension. The definitive radiation dose is a little bit higher, and that makes sense, right? Because now radiation is all you're giving as far as local therapy, so you need to take it to a higher dose. And that dose is usually 70 gray in 35 fractions. And you can deliver this as a simultaneous integrated boost as well, with other levels at 63 gray and 56 gray, all in 35 fractions. So the 70 gray goes to the primary tumor and any positive nodes. The 63 gray goes to an additional mucosal margin on your primary as well as involved nodal levels. And then 56 gray goes to whatever elective neck volumes that you're going to be treating. The only exception to this rule for definitive dosing is if you're treating the larynx. And the larynx we actually treat with hypofractionation at 2.25 gray per fraction. If it's a T1 and 0 glottic larynx, we treat to 63 gray in 28 fractions. And if it's a T2 tumor of the glottic larynx, we treat to 65.25 gray in 29 fractions. So either way, they're getting 2.25 gray per fraction, but the difference is 28 versus 29 fractions. And I have in the notes there the 5x5 versus the 6x6 centimeter fields for T1 versus T2 glottic larynx. Just to briefly recap, what is the difference between T1 and T2 glottic larynx? T1 is if it involves either one or two vocal cords. The distinction is T1A versus T1B, but the vocal cord mobility is normal. T2 is if you have impaired vocal cord mobility or if the tumor extends to the supra and or the subglottis. So that's why with T2, our field is extended by an additional centimeter. And if it's going into the supraglottis, we go 1 centimeter superior to the thyroid cartilage. If it's extending inferiorly, then we go 1 centimeter inferior into the subglottis. And then finally, remember the patients that we're adding chemotherapy. If it's post-op, it's if they have a positive surgical margin or if they have extracapsular extension. If we're doing definitive radiation, usually if they have T3 to T4 or N2 or higher disease, we're adding chemo. And the chemotherapy that we do is weekly cisplatin, and it's usually 40 milligrams per meter squared if you're doing weekly dosing, or you can do every 3-week dosing at 100 milligram per meter squared. This table just briefly reviews the elective nodal levels that you would want to cover for the different head and neck sites. So most of the time, we want to cover levels 2 through 4 bilaterally. And so that applies to nasopharynx, oropharynx, larynx, hypopharynx, thyroid. We're almost always covering levels 2 through 4 bilaterally. We cover the retropharyngeal lymph nodes when there is pharynx in the field or in the name of the disease site. So nasopharynx, oropharynx, hypopharynx. You always want to add the retropharyngeal nodes. We also add the retropharyngeal nodes for the paranasal sinus nodes. And just remember, sinus is so close to the nasopharynx, so retropharyngeal nodes apply for sinus as well. We cover level 5 for nasopharynx. So nasopharynx, you're covering not only levels 2 through 4, but they have a high rate of, sometimes they can skip and metastasize directly to level 5. So you always cover level 5 electively. The other disease site where you cover level 5 is the thyroid. And for thyroid, because those are kind of anterior or lower down in the neck, you're actually covering level 6 and level 7 as well. So 6 is kind of the pretracheal nodes, 7 is the superior mediastinal nodes. So thyroid, you're covering, slightly different field than you normally would cover for these other sites. So 2 through 4, almost always covering. 5, you're adding for nasopharynx, thyroid. Thyroid, you're also adding 6 and 7. Retropharyngeal, anything with pharynx in the name, or if it's a sinus, you're covering retropharyngeal. And then salivary glands and oral cavity, as well as sinus, you're covering level 1 lymph nodes as well. So if you're covering level 1, level 1B is usually what you're covering. So for paranasal sinus, salivary glands, oral cavity, you're going to be covering level 1B. And then level 1A, especially for oral cavity, you want to cover because those, remember, are the submental lymph nodes, and especially tumors that are kind of like the anterior floor of mouth, the lower lip, anterior tongue. These are things that can drain to the bilateral 1A lymph node. If a level is involved with, especially with more bulky nodal disease, then you can treat adjacent levels as well to a lower dose. So for example, if you are treating oropharynx and there's bulky level 2 lymph nodes, then it can make sense to include level 1B and level 5, which are on either side of that level 2 where there's bulky nodal involvement. And then the last thing I should say, there are cases where you can consider unilateral nodal coverage. And I think the best example of that is if you have a unilateral, well-lateralized, small tonsillar primary, as long as it's not involving structures that drain bilaterally. So kind of like the soft palate, the uvula, the base of tongue, those are very vascular and drain bilaterally. But if it's well lateralized and just in the tonsil, then for oropharynx, you can just do a unilateral neck field. Here are some useful dose constraints for the head and neck. I think some common ones that we should always know: the lacrimal and parotid gland mean dose should ideally be less than 26 gray. For submandibular gland, you ideally want to keep the mean less than 35 gray. Pharyngeal constrictors and oral cavity, as well as carotid arteries, you want to try and keep the mean less than 50 gray. I think the parotid gland dose is one of the more high yield doses to know, and the mean for this is less than 26 gray. And keep in mind that is when we are doing head and neck radiation. So if you're treating something like a lymphoma, for example, your overall dose is going to be so much lower. So your parotid mean should be much, much lower than 26 gray. But for head and neck, when we're going to 60 to 70 gray, we try to keep the parotid mean less than 26 gray. Submandibular gland can handle a little more, and the mean is less than 35 gray. And a lot of other means that we think about are less than 50 gray. So pharyngeal constrictor muscles, oral cavity mean, and carotid artery mean less than 50 gray. Very quickly, I wanted to touch on paraganglioma. I don't know if this would pop up in the head and neck section if it pops up, or perhaps in one of the other disease site sections. If it did come, I think that means you would be doing very well and have probably gotten through some of the more basic cases. But paraganglioma is a neuroendocrine tumor that can develop from nerve cells, and it's often related to genetic conditions, and it can commonly be seen in the head and neck region, but can occur anywhere. So sympathetic paragangliomas can exist because, again, it's a neuroendocrine tumor, so it can be associated with like a functional element or a secretory element where it's secreting elevated catecholamines. These ones are often located in the chest or the abdomen. Pheochromocytoma is an example of a related tumor that actually forms within the adrenal gland. And if it's functional, you want to check urine catecholamines prior to treatment and actually control the catecholamines before you do anything. So the management is with alpha blockers. Remember, we always avoid unopposed beta blockage, but we can give alpha blockers. Parasympathetic paragangliomas are often what are seen in the head and neck region. And these tend to be asymptomatic, meaning that they're non-secretory. But of course, if they grow very large, then they can be associated with, just local regional symptoms. Imaging features, they are highly vascular, so they enhance on a contrast CT scan. And on MRI, they have this characteristic salt and pepper appearance because they have a lot of blood flow through them, so they can create these dark areas that are vascular flow voids just from blood moving quickly through the vessels. And they can also be peppered with bright areas of hemorrhage. So that leads to that bright and dark salt and pepper appearance. These are managed kind of similar to meningiomas, only if they are enlarging or symptomatic. And in conventional dosing, they can take anywhere from 45 to 50 gray with conventional fractionation, or you can do SRS and, single fraction doses can be lower, like 16 to 18 gray, or 25 gray in 5 fractions if you're doing fractionated. We will end then by just briefly mentioning skin cancer. So what I'll say about skin cancer is that if it's a low-risk non-melanoma skin cancer, and they're for some reason not a candidate for excision or some type of alternate focal therapy, then we can do definitive radiation. And in these cases, we often favor hypofractionated approaches with electrons or skin brachytherapy. And then if you're using radiation adjuvantly for a more high-risk tumor, these are often resected, and then they have multiple high-risk factors that are very similar to some of those high-risk factors that we talked about for head and neck. With skin, we also worry about patients that are on immune suppression or patients that are having a recurrent skin cancer, especially in higher risk areas, which are often areas on the face and in the head and neck. And the radiation doses for skin cancer when you're using conventional fractionation are very, very similar to the radiation doses that we use for head and neck cancer. So I think that if this comes up on the board exam, it might be a locally advanced basal or cutaneous squamous cell cancer, probably cutaneous squamous cell because those tend to be more aggressive tumors. And the management will probably be surgery, and then they'll have high-risk factors that make you want to give adjuvant radiotherapy. And the doses are very, very similar to what we do for adjuvant radiation for the head and neck, which is somewhere on the order of 60 to 66 gray. Cutaneous melanomas, we always think about managing these with immune checkpoint inhibition, and they can be managed with surgery, so wide local excision and sentinel lymph node biopsy with completion dissection if they turn out to be positive. And then if we're using adjuvant radiation for these, 48 gray and 20 fractions is an option, or 30 gray and 5 fractions delivered in non-consecutive days. Merkel cell carcinoma is also managed with surgery and sentinel lymph node biopsy up front. And then the doses are ranging from 50 to up to 66 gray. The doses for Merkel cell carcinoma are a little bit lower than what we see for squamous cell carcinoma, and that's because Merkel cell is a highly radiosensitive histology. So if negative margins, remember 50 gray, if positive margins, 56 gray, and then if gross residual or definitive radiation, 60 to 66 gray. So in a nutshell, these are skin cancers. Moving on then to lung, mediastinum, and sarcoma. We'll start by talking about non-small cell and small cell lung cancer. We'll move on to thymoma, mesothelioma, and then we'll end with sarcoma. What are some unique aspects of lung cancer workup? Just your typical lung symptoms like chest pain, cough, shortness of breath. If they're having any dysphagia, weight loss, if they're having hoarseness, that could be indication of tumor involving the recurrent laryngeal nerve branch of the vagus nerve. Always think about their smoking history and talk about smoking cessation counseling if they've had any prior history of cancer. And then exam, pretty straightforward, but doing a lung exam, palpating for any supraclavicular lymphadenopathy. And always get a neuro exam on these patients too, because locally advanced lung cancers are at high risk of brain metastasis. Labs, we get a CBC CMP, and we also want to get PFTs. So having an FEV1 of 40% and a DLCO of 40% at the very least are recommended for medical operability. So always get your PFTs to determine if a patient is a surgical candidate. And then imaging, we get a diagnostic CT chest. FDG PET CT is also standard for lung cancer. And most patients with lung cancers need a brain MRI. So anyone with small cell lung cancer always needs to get a brain MRI. And anyone with node positive non-small cell or tumor greater than 4 centimeters needs a brain MRI. The only time you can think about avoiding brain MRI for non-small cell lung cancer patients is if they have like an early stage disease that you might be thinking about SBRT alone. But if it's a large primary or node positive, always get a brain MRI. Pathology, CT guided or endoscopic biopsy, so getting a bronchoscopy with biopsy for the primary. And then patients should always have mediastinal sampling. So if they're getting surgery for an early stage, that might happen during their lobectomy or wedge resection. But if they're getting SBRT, then the gold standard is to get bronchoscopy with FNA versus a mediastinoscopy for sampling the mediastinal lymph nodes. The management of lung cancer can be fairly complicated if you think about radiation versus surgery, who's a candidate for surgery, and what types of neoadjuvant or adjuvant therapy we give with surgery. But if we just focus on the role of radiation in the management of lung cancer, I think management is very, very straightforward. So early stage non-small cell lung cancer, patients that either are not a candidate for surgery or do not wish to undergo surgery, we typically manage these with just SBRT. So these are, your stage 1 lung cancers. They've had a bronchoscopy, nodes are all negative. These patients can be managed with SBRT alone, and a very safe dose, no matter where you are, is typically 50 gray and 5 fractions. Only if you're dealing with a very ultra-center tumor where either your GTV or your PTV is overlapping with central mediastinal structures, you might think about doing a 10 fraction regimen, such as 70 gray and 10 fractions, rather than a smaller 50 gray and 5 fraction regimen. So those would be very safe answers. Of course, there's other dose fractionation options available, and do whatever you're comfortable with. But 50 gray and 5 fractions, if SBRT is an option, is very, very standard. And then for tumors that are overlapping or abutting central mediastinal structures, there's larger regimens, and I think 70 gray and 10 fraction is a very safe option to give for that. For locally advanced non-small cell lung cancer, again, patients that are not a candidate for surgery, either for medical reasons or because they have multi-station N2 disease or N3 disease, these are patients that we typically treat with chemoradiation followed by immunotherapy. So the regimen is 60 gray and 30 fractions with concurrent chemo. Carbotaxol is a very safe concurrent chemo regimen to give because it can be given with both adenocarcinoma and squamous cell histologies. The dose is carboplatin AUC2 and paclitaxel 50 milligram per meter squared weekly. And we give that with 60 gray and 30 fractions of radiation. And we follow this with adjuvant durvalumab. So as far as the radiation is concerned for non-small cell lung cancer, if they're very early stage SBRT, if they're locally advanced, 60 gray and 30 fractions with carbotaxol followed by durvalumab. Small cell lung cancer, there's radiation involved whether you're dealing with limited stage or extensive stage. So limited stage small cell lung cancer, we'd manage with chemoradiation followed by immunotherapy. Chemoradiation, ideally we start with cycle 1 of chemo and radiation together, but if it's not possible, you can start with cycle 2. And the dose is 45 gray and 35 fractions given BID. That's generally the preferred regimen. But if for some reason they can't do that, 66 gray and 33 fractions is an acceptable alternative, and that's daily fractionation. So that's the radiation dose. The concurrent chemo that we give for small cell is cisplatin etoposide. So the dose is cisplatin 75 milligram per meter squared plus etoposide 100 milligram per meter squared. That's given every 3 weeks, and it's given for 4 cycles. After they complete their chemoradiation, they will then get adjuvant durvalumab, just like with non-small cell lung cancer. So the adjuvant durvalumab duration for non-small cell lung cancer is 1 year, and for small cell lung cancer, it's 2 years. And that is based on the Pacific trial for non-small cell and the Adriatic trial for small cell. So for both, they're going to get chemoradiation followed by durvalumab, 1 year for non-small cell, 2 years for small cell for the durvalumab. And then extensive stage small cell lung cancer, these are managed upfront with chemotherapy and immunotherapy. So they get cisplatin etoposide, and we also add durvalumab or atezolizumab for 4 to 6 cycles upfront. There is data for consolidative radiation, 30 gray and 10 fractions, if they have a good response to chemoimmunotherapy. And one thing I don't have on this slide is the role of prophylactic cranial irradiation. I think PCI has fallen out of favor amongst a lot of practitioners, but I think it's worth mentioning for board exams that if patients have a good response to upfront chemoradiation in limited stage small cell, or if they have a good response after the chemoimmunotherapy and they have good performance status for extensive stage small cell, consideration of prophylactic cranial irradiation, or at least a conversation about it, is reasonable with the patient. There's actually data for extensive stage small cell lung cancer to support just getting a surveillance brain MRI. There's also ongoing clinical trial, the Maverick study, that's looking at just doing brain MRI surveillance with intervention at the time of metastases. So I think PCI is definitely falling out of favor, but it's worth just knowing that that is something to be aware of for limited stage and extensive stage small cell lung cancer. Here are some simple dose constraints that you can memorize for lung SBRT. I'm just going to focus on that last column, which is 50 gray and 5 fractions. I think, typically we think about it if it's a tumor that's within 2 centimeters of any central structures. But 50 gray and 5 fractions is a very easy dose to give for anything in the lung if you're doing lung SBRT. So the dose constraints for this are very easy because it's a maximum dose of 30 gray, and that applies to your proximal bronchial tree, esophagus, heart, as well as your spinal cord. Great vessels can take more dose, less than 47 gray. And then there is a chest wall constraint, which is the volume receiving 30 gray should be less than 30 cc's. And that's a soft constraint, I would say, because if you're dealing with a stage 1 lung cancer and your V30 to the chest wall exceeds 30 cc's, it's fair to just accept that and counsel the patient they're at higher risk of developing chest wall pain. You never want to underdose, especially a primary lung malignancy, to meet a chest wall dose constraint, because then you're kind of sacrificing the chance of curing that lung cancer. So chest wall V30 less than 30 cc's is a very commonly cited constraint, but I wouldn't hang your hat on it. I would basically tolerate some exceptions to that if necessary, if you're dealing with something that overlaps with the chest wall. Other doses for 50 gray and 5 fractions, remember max dose of 30 gray to pretty much everything. So spinal cord, heart, esophagus, proximal bronchial tree. Here are some dose constraints for conventional lung fractionation. So your esophagus mean should be less than 34 gray, and the volumetric dose, the volume receiving 60 gray to the esophagus, should be less than 17%. The heart dose, you want to keep your V40 less than 20%. I think V50 less than 30% is an alternate that I've seen. And you want to keep your mean heart dose less than 60 gray. Lung, the most important volumetric dose for the lung is V20 less than 35 gray. There is something that you'll read, which is V5 less than 90%, but there's really not great data for that. And I don't think that the V5 matters as much as the V20. So you want to try to keep your mean for the lung less than 20 gray, and you want to try to keep your V20 gray less than 35%. So I think those are the most important for conventional dose fractionation for the lung when we're doing going to 60 gray. So esophagus mean less than 34, V60 less than 17%, heart V40 less than 20%, and lung minus GTV V20 less than 35%. For the 45 gray and 30 fractions BID regimen for limited stage small cell, you might get asked about the spinal cord dose constraint, and in the Teresi regimen, the spinal cord dose constraint was 36 gray maximum, which should be, achievable with IMRT planning. But the NCCN guidelines allow a max dose of 41 gray with that BID regimen. So these are just dose constraints to keep in mind for spinal cord with the BID fractionation for small cell lung cancer. I tried to put in one slide everything you need to know about thymoma. So thymoma can present with symptoms of myasthenia gravis, and if that's the case, we give acetylcholinesterase inhibitors to control symptoms before surgery, because these can basically secrete antibodies against your acetylcholine receptors. So acetylcholinesterase inhibitors, so that they're not having that droopy eyelid and weakness. Thymomas are managed first with resection, and there's different histologies that we can see. So there's type A, AB, B1, 2, 3, and C. Type C is thymic carcinoma, and these are always going to get adjuvant radiation. And then these other A, AB, and B histologies, we only give adjuvant radiation if they have more advanced stage disease. So that brings us to the staging, which is done by the Masaoka-Koga staging system, and we divide it into stage 1, 2, 3, and 4. 1 is if tumor is grossly and microscopically completely encapsulated. Stage 2 is if there's transcapsular invasion. 2A is microscopic invasion and 2B is macroscopic invasion, kind of infiltrating into the surrounding fat or grossly adherent, but not yet breaking through any pleura or pericardium. So it's just macroscopic transcapsular extension. Stage 3 is if then you have macroscopic invasion into your neighboring organs, so pericardium, great vessels, lung. And stage 4 is divided into A and B. A is if you have pleural or pericardial dissemination. Stage 4B is if you have distant metastasis. So the only indications for postoperative radiation, again, other than if you have thymic carcinoma, those are always going to get postoperative radiation. But the other histologies, if you have positive margins or stage 3 disease where there's, gross invasion into neighboring organs, that's when you do radiation. And the dosing is based on the extent of resection. So we do 45 to 50 gray for negative margins, 54 to 60 gray for positive margins, and then 60 to 70 gray for gross residual. So I just remember 50, 54, and 60. So 50 gray for negative margins, 54 if it's positive, and then 60 if there's actual disease that you're treating. Mesothelioma, I am very much hoping this is not on the board exam because the management is quite controversial and it's such an aggressive disease with a high risk of metastasis that systemic therapy really is kind of the mainstay of treatment. And in real life, I've never treated a mesothelioma definitively, only palliatively, and often that's just SBRT to, oligometastatic pleural metastases. But that said, I think we should be just generally aware. We can manage mesothelioma with neoadjuvant or adjuvant systemic therapy, and the regimens are cisplatin, pemetrexed with bevacizumab, or ipilimumab and nivolumab. And select patients could be candidates for surgery. They used to do extrapleural pneumonectomy, but now pleurectomy with decortication is preferred because that spares more lung. And, neoadjuvant chemo followed by pleurectomy and decortication could be an approach. But there are recent MARS and MARS-2 studies that actually suggest worse survival with surgery. So we may even be moving away from surgery and managing these. And then the role of radiation is also highly controversial because radiation is thought to decrease the local recurrence risk after surgery, but there's not a ton of strong data to support this. If you are giving adjuvant radiation, the doses are kind of similar to what we talked about for thymoma, where we do 50 to 54 gray if there's negative surgical margins, 54 to 60 gray if there's positive surgical margins. It's IMRT, it's 1.8 gray per fraction. And, many are wary of any benefit to adjuvant radiation, especially if there's gross residual, just because it's such a poor prognosis. So many just save radiation for palliative settings. Sarcoma may also pop up on this section. So just some key aspects for sarcoma workup. You always want to thoroughly examine the primary mass and, the respecting draining lymphatic region. So for example, if you have a thigh mass, examine their popliteal nodes and their inguinal nodes on that side. Imaging, an MRI with contrast, the tumor will usually appear hypointense on T1, hyperintense on T2. You always get a CT chest to rule out thoracic metastases because that's where it's most commonly metastatic. And the role of PET-CT is kind of evolving, but for sarcomas, generally you get an MRI of the primary site and then a CT chest to rule out metastatic disease. Biopsy should be a core needle biopsy, and it needs to be done longitudinally along the same plane as the tumor so that the biopsy scar can be resected at the time of surgery. And therefore, the biopsy is ideally done by the same surgical or orthopedic oncologist that will do the operation. For retroperitoneal sarcoma, you can actually get a CT-guided retroperitoneal biopsy to avoid seeding the peritoneum. But for extremity sarcoma, remember a longitudinal biopsy tract to get core needle biopsy along the same plane as the excision, ideally by the same surgeon that will operate. So with extremity sarcomas, the goal of management is functional limb preservation, right? And we know that historically these patients were managed with amputation, but we found that we could reasonably treat them with surgery and radiation and then that allows them to spare amputation. So ideally, we want to get an en-bloc resection with negative margins, and ideally we want that margin to be clear by over 1 centimeter. And the radiation treatment can be given either preoperatively or postoperatively, and it's really indicated for stage 2 to 3 disease. And with sarcoma, the grade is actually important for the stage. So grade 1 sarcomas can typically be managed with surgery alone. It's grade 2 to 3 sarcomas that are at a higher risk of local recurrence, which is where radiation helps improve local control. So radiation can be given preoperatively or postoperatively. The preoperative radiation dose would be 50 gray and 25 fractions. The only exception to that is myxoid liposarcoma, where there's data for giving 38 gray and 18 fractions per the DORE-MI trial. So pre-op, remember 50 gray and 25 fractions, but 38 gray and 18 fractions in the DORE-MI trial. The postoperative dose is higher. It's 60 gray and 30 fractions. And if they have a positive margin, we need to go up to 66 gray. If they have gross residual disease, we need to go even higher to 70 to 76 gray. Now, there's a lot of drama around pre-op versus post-op radiation, and the studies basically show that preoperative radiation is what we prefer. So the reason for this is that preoperative radiation decreases long-term fibrosis, edema, it improves long-term functional outcomes. Because with preoperative radiation, we're able to keep our radiation field smaller, we're able to go to a lower dose, and it then results in less long-term complications. The downside of preoperative radiation is that we have higher acute wound complications. So the rate of acute wound complications is about 35% with pre-op versus 17% with post-op. But that's a short-term complication, and patients can heal from these acute wound complications. So we as a field generally prefer preoperative radiation because it decreases those long-term functional outcomes, or complications, I should say. So the preoperative dose is 50 gray and 25 fractions, but if you have myxoid liposarcoma, 38 gray and 18 fractions. Just some pearls for radiation planning for sarcoma. So when we're giving preoperative radiation, the margins are fairly straightforward. So you contour your GTV. You do a 1.5 centimeter radial margin cropped out of barriers to spread, and you do a 3 to 4 sup inf margin along the long bone because these, can spread, pretty high. So similar to esophagus cancer where you use really large sup inf margins for that concern for lymphatic spread. With sarcoma of the long bones, you do the same exact thing. And then you can do a 5 millimeter PTV margin and take that all to 50 gray. For postoperative radiation, the dose, as we said, is 60 gray and 30 fractions, but we go higher if there's a positive margin or gross residual disease. So we actually have a cone down situation for post-op radiation. So you take the tumor bed, which is probably going to be bigger than the original GTV to begin with. So that includes any surgical clips, use your preoperative MRI to kind of understand where that tumor bed is. And you're going to do the same 1.5 centimeter radial, 3 to 4 centimeter sup inf margin. That, with your 5 millimeter PTV margin, will go to a dose of 50 gray. And then you'll boost a smaller area, so the same tumor bed, but instead of doing a 3 to 4 sup inf margin, you just do 1.5 to 2 centimeter sup inf margin. And that's the area that you take to your higher dose of 60 to 66 gray. Some important dose constraints for treating sarcomas of the extremities. Your long bone mean dose should be less than 37 gray. Your point dose should be less than 59 gray. And then you want your V40 to be less than 64%. So if you're going to remember two things, you want your mean less than 37 and you want your V40 less than 64% for long bones. And then also it's nice to avoid the circumferential 50 gray isodose line from encompassing your long bone. So you don't want 50 gray around the entire circumference of your long bone. So if you're going to remember anything, remember mean less than 37, V40 less than 64, And then nice things to remember are a point max of less than 59 and avoiding 50 gray isodose line from completely circumscribing your long bone. And then another important dose constraint for extremity sarcoma is the skin strip. So you want to contour a 2 centimeter skin strip somewhere on the extremity, usually opposite the area of where you're treating. And you want to keep the V20 gray to that 2 centimeter skin strip to be less than 50%. So your 2 centimeter skin strip should be V20 less than 50%. And the reason for this is that you don't want to completely obstruct and damage the lymphatic drainage of the skin of your extremity. So V20 less than 50%. We really focused on the role of radiation in managing extremity sarcoma. I just want to end with a quick note on retroperitoneal sarcoma. So there was a recent STRASS trial that was negative for the benefit of preoperative radiation for retroperitoneal sarcomas, but there was a subset analysis that suggested that pre-op radiation may have provided a benefit for liposarcoma specifically. So if you have a retroperitoneal liposarcoma, you can do radiation, but for any retroperitoneal sarcoma, preoperative radiation is very, very strongly favored over postoperative radiation. So if you're going to do radiation for sarcoma, for retroperitoneal sarcoma, make sure it's pre-op. And specifically, it's liposarcoma histology that benefits from that pre-op radiation. The volumes for retroperitoneal sarcoma, since it's retroperitoneal, you want to get a motion study and make sure that you're creating an ITV, so a GTV, and then account for motion to make your IGTV. And then you can add a 1.5 centimeter circumferential CTV margin for retroperitoneal sarcoma. Moving on to the next section, which is heme and benign. So in this section, we'll talk about Hodgkin, non-Hodgkin, and cutaneous lymphomas, myeloma, plasmacytoma. We'll mention acute and chronic leukemias and the relatively limited role of radiation for leukemia. And then we'll end with some benign indications for radiation and just really focus on the dose fractionation that you would use. So with lymphomas, the important things to know about workup. In your H&P, you always want to ask about B symptoms, and that is defined as fevers greater than 100.4 degrees Fahrenheit, drenching night sweats, or over 10% unintentional weight loss within the last 6 months. You always want to assess lymphadenopathy and splenomegaly on exam. And labs, get CBC-CMP. You want to get ESR and LDH as well. And then for young women, make sure you get a pregnancy test, and you can test for HIV, HBV, HCV. Pathology for lymphoma, you need to get either an excisional or a core needle biopsy because FNA is inadequate. Bone marrow biopsy is something that comes up a lot for lymphoma, but if you read the NCCN guidelines, the only time bone marrow biopsy is really, really needed is for early stage low-grade lymphomas, such as follicular lymphomas, that you are thinking about treating definitively. Follicular lymphoma, there is an option to just observe even early stage patients because this is a very indolent lymphoma and it's thought that there's a pretty high likelihood of malignancy. If, however, you are going to treat these patients definitively, then it's better to get a bone marrow biopsy just to make sure that they don't have disseminated disease already. So early stage follicular lymphoma that you're thinking of managing definitively, do get a bone marrow biopsy. For a lot of the other lymphomas, bone marrow biopsies have fallen out of favor now that we have PET staging. So for Hodgkin lymphoma, for diffuse large B-cell lymphoma, if you read the NCCN guidelines, you typically do not need bone marrow biopsy unless they have other unexplained cytopenias or there's concern for something on PET that's not clear on PET imaging. Other tests to think about, these patients often will need doxorubicin, so you need to get an echocardiogram or a MUGA scan to evaluate heart function, and then get pulmonary function tests if you're going to be giving them bleomycin. And for imaging, it's very, very, very important to get a PET scan. And you get a PET scan pre-treatment, and then post-treatment, you use a Doval score to assess the response. So usually scores of 1 and 2 Doval score are defined as a complete response. 3 can be defined as a complete response. Some studies characterize it as a partial response. And then the Deauville score, I would just know, what 1 through 5 means. I always remember the score of 3 is where there's uptake more than the mediastinum, but less than the liver. And then the rest of the scores, I can just remember around knowing what 3 is. And then finally, as far as workup, you want to get neuroaxial imaging and lumbar puncture if there's any concern for CNS involvement or if you have a CNS lymphoma. So here are the general treatment paradigms and the role of radiation for Hodgkin and non-Hodgkin lymphoma. Let's start with Hodgkin lymphoma, which remember is CD15 and CD30 positive. The role of radiation is really limited to management of early stage Hodgkin lymphoma. Even there, there's options where we can omit radiation, but for advanced Hodgkin, we typically do chemotherapy alone. And then for early stage Hodgkin, that is where there's a potential role for radiation. And these are radiation oncology boards. So if you're managing an early stage Hodgkin lymphoma, I would just say you're treating them with radiation. Now, Hodgkin lymphoma patients with early stage disease are divided into favorable versus unfavorable based on certain criteria. There's different criteria by different cooperative study groups. I just remember the German Hodgkin study group criteria, which is bulky disease over 1/3 mediastinal mass ratio, having an ESR of over 50 or an ESR over 30 if they have B symptoms, having any number of extranodal sites, or having 3 or more nodal sites of disease. So you can remember this with the B's mnemonic, BEES, bulk, ESR, extranodal, and the number of sites. 3 or more for the German Hodgkin study group criteria. So if they don't have any of those unfavorable factors, they are classified as favorable disease, and the management is with ABVD times 2 cycles. Then you get a PET scan, and if they have a complete response on PET scan, you can treat with 20 gray and 10 fractions involved site radiotherapy. And that's a key buzzword for any time you're doing radiation for lymphoma, involved site radiotherapy. So early stage favorable, it's ABVD for 2 cycles, and if they have a complete response, 20 gray and 10 fraction involves site radiotherapy. If they meet any of those B's criteria and they are then classified as unfavorable, then we do ABVD for 4 cycles, and if they have a complete response to the 4 cycles, then we can do 30 gray and 15 fractions ISRT, okay? So I think the Hodgkin treatment paradigm, if you just remember the German criteria that make you favorable versus unfavorable, if you're favorable by German criteria, it's ABVD times 2 followed by 20 gray. If you're unfavorable, it's ABVD times 4 followed by 30 gray. And of course, if they don't have a complete response on interval PET scan, then you give them more chemotherapy, and then you probably need to give them a higher dose of radiation, at least 30 gray, if not even closer to 40 gray if they still have residual disease. So that's Hodgkin in a nutshell. Non-Hodgkin lymphomas, these are CD19 and CD20 positive, and the non-Hodgkin lymphomas, we typically divide them into the high-grade lymphomas versus the low-grade indolent lymphomas. So high-grade lymphomas are lymphomas such as DLBCL. And with DLBCL on histology, some important things to know are that these can be divided into germinal center B-cell lymphomas versus non-germinal center or activated B-cell subtypes. The ABC subtype is more aggressive. The GCB subtype is less aggressive. The other thing that we look for is amplification or rearrangement of BCL2, BCL6, and MYC-N. The significance of that for DLBCL is that if they have amplification or rearrangement, they are known as double expressor or double hit or even triple hit you can have. And these are more aggressive features, and we often consider escalating our chemotherapy for those patients. So as far as management, DLBCL is managed with R-CHOP for 6 cycles. And then, keep in mind that if they have aggressive subtypes, so say they have that double hit or triple hit histology, or if they have aggressive subtypes such as primary mediastinal B-cell lymphoma, We can even escalate the chemotherapy with something called EPOCH-R rather than just R-CHOP. So we're adding etoposide to the drugs in R-CHOP. Once they get 6 cycles of R-CHOP, if they have a complete response, most patients don't need adjuvant radiation, but you can consider 30 to 36 gray of involved site radiation for patients that have bulky disease defined as over 7.5 centimeters, or if they have skeletal involvement. So bulky disease or skeletal involvement are indications for radiation if they have a complete response to R-CHOP, and the dose is 30 to 36 gray. Now, if they have a partial response, then you probably will consider radiation. Oftentimes, these patients will get CAR T-cell therapy, but you'll consider doing radiation, and radiation can be somewhere between 40 to 50 gray if you're still dealing with gross residual disease. Then we have low-grade lymphoma, such as follicular or marginal zone lymphomas. And remember, we talked about for follicular lymphoma that's early stage, you want to get a bone marrow biopsy just to make sure they don't already have disseminated disease, unless you are observing. Now, follicular lymphoma is graded into grades 1, 2, and 3, and 3 is actually divided into grade 3A versus 3B. And if you have grade 3B follicular lymphoma, that is when the cells have sheets of centroblasts. You actually treat this as a high-grade lymphoma. So you treat it similarly to DLBCL. So if you get a grade 3B follicular lymphoma, treat it like a DLBCL, give them R-CHOP. But all the other follicular lymphomas, grade 1, 2, and 3A, you can manage with a similar paradigm. And low-grade lymphoma management, I think, is fairly easy. So most of the time, if they have early stage disease, you can just give them 24 gray and 12 fractions. And that's a pretty standard dose for almost all low-grade lymphomas. The only time you might think about giving a lower dose is if they have advanced stage disease or they're very frail, poor performance status, and you're treating them super palliatively. Then you can do the quote-unquote boom-boom regimen, which is 2 gray times 2, 4 gray, and 2 fractions. Even some early stage disease, if you're treating, like say, a 90-year-old person with a single site of disease, you can still try the boom boom regimen. And then if they don't have a great response, you can just treat them with more dose later. But 24 gray and 12 fractions or 4 gray and 2 fractions are perfectly reasonable options for low-grade lymphoma. Some dosing and dose constraints. So we kind of already went through this, but the classic Hodgkin lymphoma dosing that we think about, 20 gray and 10 fractions for early stage favorable that have a complete response to 2 cycles ABVD. And if they are early stage unfavorable, we give them 4 cycles of ABVD, and we do 30 gray and 15 fractions if they have a complete response. Non-Hodgkin lymphoma dosing, if we're really just doing consolidative radiation after a complete response, it's 30 to 36 gray. If it's a partial response, then it's 40 to 50 gray. And if they are not a candidate for chemotherapy, then we treat them to much higher doses of 40 to 55 gray. And if we're giving radiation combined with a stem cell transplant, then we can give lower doses of 20 to 36 gray. There's one more type of Hodgkin lymphoma called nodular lymphocyte predominant Hodgkin lymphoma. This is thought of as a non-classic Hodgkin lymphoma, and it's also being reclassified as a B-cell lymphoma. Unlike Hodgkin that is CD15 and CD30 positive, the NLPHL is CD20 positive and CD45 positive. It has those popcorn cells on histology, and this can be managed similar to a low-grade B-cell lymphoma, and you can treat it to radiation alone. You can do 30 gray, or if it's bulky and over 5 centimeters, you can do 36 gray. As far as dose constraints for lymphoma, just keep in mind that you never want to give dose constraints for any area in the body that you're treating that you might use for disease sites where you treat to much higher doses. So for example, if you're treating a cervical lymphoma, you never want to say that you want to keep your mean parotid dose less than 26 gray, the way we do for head and neck, because you're not going to 60 to 70 gray. So your mean parotid dose should really be much, much, much lower than 26 gray. And there's a nice paper, first author, Dr. Dabaja, for mediastinal dose constraints in lymphoma. And I think these are some good dose constraints to have in the back of your mind. So these are all ideal dose constraints from that paper. And in that paper, there's additional tables with higher doses that are acceptable. And of course, it's really going to depend on the extent of upfront disease and how large of a field you need to treat. But a mean heart dose to keep in mind for lymphoma is less than 5 gray and V15 less than 10%. Mean lung dose should be less than 8 gray ideally, and your V20 should be less than 20%. So notice lung cancer, we do V20 less than 35%. For lymphoma, we try to keep lung dose V20 less than 20%. Thyroid, you want your V25 gray to be less than 62.5%. And you want your breast mean to be less than 4 gray, and you want your V4 gray to be less than 10% for the breast. So if you're going to remember means, remember heart, lung, breast. Heart mean less than 5, lung mean less than 8, breast mean less than 4. And remember that quirky thyroid constraint, that'll probably get you extra points. It's V25 less than 62.5%. I have a whole bunch of extranodal lymphomas listed here in this table, and I'll just quickly try to go through the different types that you might encounter and highlight some pearls around them. So primary CNS lymphomas, these are often located kind of right in the center of the brain. They often have subependymal extension, and they often cross the corpus callosum. They're typically managed with upfront chemotherapy, high-dose methotrexate, and sometimes even intrathecal chemotherapy. But you should know that a high-dose methotrexate-based chemotherapy regimen is recommended for the upfront management of CNS lymphoma. And then you kind of assess your treatment based on the response. So if they have a complete response, we used to often do whole brain radiation to a dose of 23.4 gray standardly as consolidation, but it's now no longer considered the best option for symptom control just because it can increase neurocognitive toxicity a lot. And giving any type of whole brain radiation after methotrexate, especially in older people, is really associated with significant toxicity. So nowadays, if patients have a complete response to the high-dose methotrexate-based chemo, whole brain radiation has fallen more out of favor. For patients that have a partial response to that chemotherapy regimen, we will give them 30 to 36 gray whole brain radiation, followed by a 45 gray boost to residual. Orbital lymphoma, the dose will depend on if it's low-grade or high-grade lymphoma. So we give 24 gray if it's an indolent histology, or 30 to 36 gray if it's an aggressive histology like DLBCL. NKT cell lymphoma nasal type is a really, really aggressive type of lymphoma that requires high doses of 50 gray or more, as well as unique chemo regimens. So these are often treated with chemotherapy. There's something known as a SMILE regimen, which sounds terrifying, followed by doses of 45 to 50.4 gray. And one thing you can do is actually give 50 gray of radiation, evaluate response, and then boost any residual with an additional 5 to 10 gray. Gastric malt lymphomas, these are often associated with H. pylori infection, so you do want to test for H. pylori, and if it's positive, you can actually give antibiotic therapy, so you can give triple therapy antibiotic. There is a mutation that we can see, or a translocation rather, the T1118 translocation for gastric malt lymphoma, and this confers resistance to antibiotics. It's typically more aggressive and you need radiation for it. And the dose of radiation is usually 24 to 30 gray, typically 1.5 gray per fraction. Just go a little bit slower for treating the entire stomach. And then finally, testicular lymphoma is unique because the testes are a sanctuary site, similar to CNS. So if you have testicular lymphoma, you typically manage with upfront orchiectomy with that high inguinal ligation, similar to what we do for seminoma. And then they need some prophylaxis to other sanctuary sites. So they might need chemotherapy, and then they'll also need intrathecal methotrexate for CNS prophylaxis, and they'll need prophylactic radiation to the contralateral testes to prevent disease from happening there, because the testes and CNS are sanctuary sites. They're not going to get enough chemotherapy. So you give intrathecal methotrexate after the chemo. And then for the contralateral testes, we typically treat them to 24 to 30 gray as prophylaxis. And then we have some primary cutaneous lymphomas to keep in mind. So for Primary B-cell lymphomas that are more indolent histologies like follicular center or marginal zone lymphoma, we just treat the involved lesion to 24 to 30 gray. For primary cutaneous diffuse large B-cell lymphoma leg type, that's a particularly aggressive subtype of B-cell cutaneous lymphoma, and these patients need chemotherapy up front, so R-CHOP for 6 cycles, followed by 36 to 40 gray of radiation. Primary cutaneous NKT cell lymphoma nasal type is, again, similar to what we talked about previously, very, very aggressive as well, and needs 50 gray with a 5 to 10 gray boost. And then we have mycosis fungoides, which we can typically just treat palliatively because these patients often have multiple sites. And we can treat them with 8 to 12 gray at 3 to 5 gray per fraction. So a common regimen that I use is 8 gray and 2 fractions for mycosis fungoides. For patients that have a single lesion, that's very rare with mycosis fungoides, but you can treat that more definitively with 24 to 30 gray. And then keep in mind that if they have a significant percentage of their skin involved, then total skin electron beam is an option for these patients too. Then we have myeloma and plasmacytoma. Plasmacytoma is a neoplasm of plasma cells, and it's often thought of as a precursor to multiple myeloma. The distinction between these two is that myeloma has over 10% of plasma cells in the bone marrow, and you meet those CRAB criteria, so hypercalcemia, renal insufficiency, anemia, and having bone lesions. Plasmacytoma is like a precursor to multiple myeloma, but you only have one tumor, and you don't have more than 10% of plasma cells in the bone marrow. It's less than 10% plasma cells. So plasmacytoma is divided into a solitary bone plasmacytoma versus an extramedullary plasmacytoma. And keep in mind that solitary bone plasmacytoma is already in the bone, so it has a higher risk of progressing to multiple myeloma. About 50 to 70% chance. It's still high, 15 to 30% with an extramedullary plasmacytoma, but if it's already in the bone, then you're going to have a higher chance of progressing to multiple myeloma. So plasmacytoma we manage with definitive radiation alone, and we give a much higher dose of radiation because we're technically trying to treat this definitively, even though we know they have a high chance of developing multiple myeloma. And the dose is anywhere from 35 to 50 gray at 1.8 to 2 gray per fraction. So I've often treated these to somewhere between 40 to 45 gray. For multiple myeloma, the management is really systemic therapy, and oftentimes these patients get stem cell transplants, and the role of radiation is really palliative. So examples of palliative doses are 20 gray and 5, 24 gray and 8 fractions, 30 gray and 10 fractions. Keep in mind that if you have hardware present for multiple myeloma lesions, like if they've had, orthopedic surgery, do some procedure, if they do have hardware, you don't necessarily need to cover the entire extent of the intramedullary rod. With bone mets, we do cover it because we are concerned about a risk of seeding of disease. But for multiple myeloma, there's been data that the risk of seeding is actually very low, less than 5%. So you only need to cover the symptomatic site and the area of the lesion. That brings us to the very limited role of radiation in the management of leukemias. And I've tried to just kind of list out different indications for radiation in the setting of leukemia. So one of them is for patients with leukemias that are getting total body irradiation for myeloablative purposes ahead of a transplant. And a very standard regimen that's used is 12 gray and 6 fractions BID. But of course, this definitely varies depending on the specific protocol for transplant. So whatever transplant protocol your transplant team is using, they'll tell you what the TBI dose is. But one common regimen is 12 gray and 6 fractions given BID. We block the lungs after 8 gray of dose, and we use ultra low dose rates using less than 20 centigrade per minute rather than what we normally use for standard external beam radiation because just out of fear of causing a lot of toxicity. So TBI is one indication for radiating patients with leukemia. It's for myeloablation ahead of a transplant. You can consider radiating sanctuary sites. Nowadays, we often use chemotherapy, but you can do CSI for sanctuary site prophylaxis, so something like 12 to 18 gray CSI or 24 gray for overt disease, 24 gray to the testes if patients have leukemia with testicular relapse. You can do palliation for splenic sequestration that happens in patients with CML, and the splenic sequestration palliative radiation dose is 5 to 10 gray given at 0.5 to 1 gray per fraction, so very low dose of radiation daily. And you actually titrate this based on the blood counts. So if the blood counts drop significantly, you stop, or if patients have a splenic infarct, you stop because you're concerned about rupture. And then finally, some patients with leukemias may present with extramedullary disease, where they actually form solid tumors outside of the bone marrow. And when these happen, these are known as chloromas, or you might also hear the term myeloid sarcoma. And the standard radiation dose for extramedullary disease with leukemia is 24 gray and 12 fractions. And then finally, here are some benign indications for radiotherapy and some common dose fractionation regimens that are used. So I'm not going to read through all of them, but some common ones that we see. Treating osteoarthritis, we do low dose radiation, 3 gray given in 6 fractions, so 0.5 gray per fraction, every other day to the involved area. Keloids, these are often resected by plastic surgery, and then we start radiation ideally the same day or within 24 hours of surgical excision, and the dose is usually 18 gray and 3 fractions daily. Dupuytren's contracture, you can do 30 gray and 10 fractions, but with a 2-week break, so it's a split course. So you do 1 week of 5 fractions, then you give a 2-week break, and then you do another week of radiation for a total of 30 gray. Plantar fasciitis, 6 gray and 6 fractions daily. Heterotopic ossification, you do 7 to 8 gray and 1 fraction, and you're trying to treat kind of the muscle and the soft tissue around the joint where those heterotopic kind of bony islands can form. And the time frame is very important for HO prophylaxis. You can either do radiation preoperatively, like 24 hours pre-op, or ideally within 48 to 72 hours post-op. So take a deep breath, because that is 4 out of the 8 sections, and I did try to front load with the more time-consuming sections, also the sections that more of us are maybe less likely to see in our actual practice, like, a lot of us see CNS, but pediatrics I think is rare, and also lymphoma is fairly rare. So the second half of this talk, we're going to be talking about GI, GU, GYN, and breast. So hopefully these are more commonly seen disease sites in clinic, so we can maybe go through these a little bit more quickly than the prior sections. So if you think about all the sites that are covered in GI, we have, obviously our upper GI, and then we have lower GI, and these are totally different beasts. So workup is really specific to the site that we're treating. So you always want to ask site-specific symptoms in your history, whether they've had bleeding, pain, bowel changes, dysphagia, early satiety, jaundice, weight loss. For rectal and anal, you always want to do a digital rectal exam. Labs, you get your CBC, CMP. CMP will tell you about LFTs. It can tell you about albumin, bilirubin, things that go into your child's Pew score, if that's something that you need to think about. And then cancer markers. So for example, CEA is useful for colorectal cancer, CA19-9 we use for pancreas cancer, AFP we use for liver. For pathology, generally getting any type of pathology is going to involve doing some type of a scope and getting a biopsy. So if you're dealing with pancreas cancer or esophageal cancer, it's an upper endoscopy. If it's colorectal cancer, it's usually a colonoscopy. Usually the histology is adenocarcinoma, and you need to assess the grade and differentiation. Anal cancer is usually squamous cell carcinoma. And then for all of these tumors, you want to get MMR and MSI testing, because if MMR deficiency is present, or if you have MSI high, then these patients respond very, very well to immunotherapy. And then there's other molecular testing, for example, HER2, which is especially important for patients with metastatic disease because they can get targeted therapy based on that. Imaging, CT chest, abdomen, pelvis, MRI is especially important for rectum, and then PET-CT is especially important for esophageal and anal cancer. So here is a table with the general management paradigms for common disease sites within the GI system. In this table, I've really focused on the radiation-specific management. So whenever radiation is involved, you should be aware that for certain cancers, there are options for management that avoid radiation altogether. So esophageal adenocarcinomas, there's an option to just do perioperative FLOT chemotherapy, and then they get surgery. So they get FLOT, surgery, more FLOT for esophageal adenocarcinoma specifically. And then for rectal cancer, there's also perioperative FOLFOX regimen based on the Prospect trial, where they get FOLFOX, surgery, and then more FOLFOX. This table specifically focuses on when radiation is given, and you should be aware that there are options for management that avoid radiation, but you'll never be wrong on Rad Onc boards for recommending management with radiation. So going one by one, the general management paradigms. So for esophagus, we can do chemoradiation up front, followed by surgery. And then if patients do not have a pathologic complete response, meaning they still have residual disease at the time of surgery, then we give adjuvant nivolumab after surgery. And that's kind of the radiation-focused management for esophagus. For pancreas cancer, if they are resectable up front, then they should get surgery. You can consider giving neoadjuvant chemo, but surgery is the only known cure for pancreas cancer. So if they can get surgery, they should get surgery. And you should be familiar with kind of resectability criteria for pancreas cancer. And following surgery, they get adjuvant chemotherapy for sure. And we give adjuvant chemoradiation if they have risk factors such as positive margin or positive nodes. If they are borderline resectable or unresectable, then they typically get chemo first, followed by radiation, whether that's chemoradiation or SBRT. For gallbladder and biliary cancers, these are kind of heterogeneous because they can be intrahepatic versus extrahepatic biliary, or they can be gallbladder. They typically will get surgery first, and then adjuvant chemoradiation if they have positive margin or positive nodes. Rectal cancer, we can manage these with total neoadjuvant chemotherapy, where they get chemoradiation followed by chemotherapy, and then we do a wait and watch approach, and if they have residual disease clinically, then they get a total mesorectal excision. And of all of these cancers, anal cancer, which remember is squamous cell histology most of the time, this is the only cancer that's actually managed with definitive chemoradiation. And the reason for this is, number one, squamous cell cancers tend to be very sensitive to radiation and they respond well. And number two, if patients with anal cancer needed surgery, they would end up with a permanent colostomy. So doing definitive chemoradiation allows you to kind of avoid that altogether. So as far as the radiation dose for all of these different diseases, for GI, if you say 50.4 gray in 28 fractions, you're probably not going to be wrong, because if you look at this table, almost all of these have 50.4 gray in 28 fractions. Some things to kind of keep in mind. With esophagus, we usually do 45 gray to a larger volume with a more generous soup and margin, and then we cone down to 50.4 to 54 gray to kind of a smaller margin around the tumor. For anal cancer, we actually do a simultaneous integrated boost. And if they have T1 to T2 N0 disease, they can just get 42 gray in 28 fractions to the pelvis, and then 50.4 gray simultaneous integrated boost to the primary. If they have T3 positive, or T3 to T4 rather, or node positive disease, then we do 30 fractions rather than 28, and they get 45 gray to the pelvis, and then they get 54 gray to the primary, and we also boost the nodes to 50.4 to 54 gray. And remember, with anal cancer, we also want to include the inguinal nodes, not just the pelvic nodes. As far as concurrent systemic therapy is concerned, with esophagus, we do carbotaxol. So the regimen is actually very similar to lung cancer regimen, which is weekly carboplatin AUC2 and paclitaxel 50 milligram per meter squared. Pancreas cancer, biliary cancer, and rectal cancer, they all get capecitabine, 825 to 830 milligram per meter squared, given BID only on the days of radiation. And then for anal cancer, the regimen is unique. It's 5-FU and mitomycin C. So we give 5-FU 1,000 milligram per meter squared days 1 through 4. And then we give mitomycin C 10 milligram per meter squared as a bolus. And this is done for 2 cycles given every 4 weeks. And keep in mind with that second cycle of mitomycin C, blood counts can really tank, and this is where patients can get sick and end up in the hospital. Here are some dose constraints that are applicable for any time you're doing conventionally fractionated radiation within the GI tract. Small bowel and large bowel maximum dose, you always want to keep less than 56 gray. A small bowel constraint that I have committed to memory is a V45 gray, less than 150 cc's. You can tolerate up to 195 cc's max, but ideally you don't want to go above that. Femoral heads, you want to try to keep your V40 less than 35%, your V30 less than 50%. Kidneys, you want to keep your mean less than 18 gray, and you want to keep the dose to 70% less than 20 gray. Liver, you want to try to keep your mean less than 25 gray, and you want to try to keep your dose to 60% less than 30 gray. So of all this, if you're going to remember anything for the GI, stomach, small bowel, these are the things that tend to be most sensitive to radiation. So keep in mind a max dose of 56 gray. And for the small bowel or your bowel bag, you want to try to keep your V45 gray less than 150 to 195 cc's. I wanted to take a couple of slides just to hit important points about pancreas SBRT and liver SBRT in case this pops up. But if you're thinking about doing pancreas SBRT, remember that any tumor invading into the duodenum is a strict contraindication to pancreas SBRT, because if you treat that, you will burn a hole in the duodenum, and that'll be very, very bad. So if you're going to do pancreas SBRT, these patients need to get an upper endoscopy ahead of time to confirm that there's no duodenal invasion. When you simulate these patients, it can be ideal to actually have fiducials placed prior to simulation. You want the patient to be NPO for 4 hours prior so that their stomach is not distended. And then at the time of simulation, you obtain a 4D CT scan, and you can consider motion management with either breath hold or with abdominal compression, but always think about the motion. And it's not listed on this slide, but you can give contrast as well, at least IV contrast, if not IV NPO contrast. A common dose fractionation regimen for pancreas SBRT is 40 gray and 5 fractions to the gross tumor and the tumor vessel interface, and then a dose of 25 gray and 5 fractions to an elective volume that includes your celiac, superior mesenteric, and peripancreatic lymph nodes. Important dose constraints for pancreas SBRT that apply to the duodenum, stomach, and small bowel, which should all be contoured separately. V33 gray less than 1 cc, V20 gray less than 3 cc, and V15 gray less than 9 cc's. And your point max should be less than 36 gray. So 33 less than 1 cc, 20 less than 3 cc, and 15 less than 9 cc. And you can consider doing a PRV for these organs at risk as well. Esophagus, you want to keep your max less than 38 gray. You can also do 20 less than 3 cc's for that. Colon, you want to keep your max less than 52.5 gray, and you can do a 32.5 gray less than 20 cc's. Kidney, you want to try to keep your dose to 200 cc's less than 17.5 gray, and your V12 gray less than 75%. If the tumor is not exactly in the midline, it's leaning to one side versus the other, you want to try to spare the contralateral kidney more than the ipsilateral kidney. But of all these, if you're going to remember any dose constraints, remember the dose constraints for the duodenum, stomach, and small bowel, because these are the same across the board, and these are the most sensitive organs. So 33 gray less than 1 cc, 20 gray less than 3 cc's, and 15 gray less than 9 cc's for those, and a point max of 36 gray. Liver SBRT is utilized for treating either hepatocellular carcinoma that's not a candidate for surgery, or other, focal therapy to the liver, such as radiofrequency ablation or chemoembolization, or it can be used to treat metastases to the liver. So it's excellent for managing both. A BED of over 100 gray is probably more important for liver mets. For HCC, you want to try to keep a BED of over 85 gray. The nice thing about liver SBRT is that with a lot of these other treatments like chemoembolization or radiofrequency ablation, you're really worried about the proximity to large vessels, such as the heat sink effect, invasion of vessels, or thrombosis. You're less worried about these things with liver SBRT. The things you have to be careful about with liver SBRT, though, is if the tumor's abutting your critical GI structures like stomach, duodenum, small bowel, that can be tough to get liver SBRT. And I've listed here as a relative contraindication, but I think what you really just need to do in that situation is to treat them with a more protracted fractionation, so 10 to 15 gray rather than SBRT. And then other relative contraindication is patients with decompensated liver cirrhosis. So get a Child-Pugh score that, remember, uses your T-bili, albumin, INR, and whether they have ascites and encephalopathy. And if they have a Child-Pugh B score of 8 plus, so if they're CPB 8, or if they have Child-Pugh C liver failure, then these are relative contraindications to liver SBRT. And most people won't offer SBRT for a CPB 8 or higher or Child-Pugh C. For simulation, very, very similar to what we talked about for pancreas. You can do fiducials prior. You can get them NPO for at least 4 hours prior. You want to get a 4D motion scan, somehow account for motion management, whether that's with breath hold or abdominal compression. And you want to give IV contrast for the liver. And common doses are 50 gray in 5 fractions or 48 gray in 3 fractions. The duodenum, stomach, and small bowel constraints are exactly the same as what we talked about for pancreas SBRT. Kidney dose constraint is 300 cc less than 12 gray on the right and 200 cc less than 12 gray on the left. And then the liver constraints that are most important to know, you want to keep your 700 cc's less than 15 gray, 500 cc's less than 12 gray, and a mean less than 13 gray. And this is your liver minus GTV. So if you remember any of these, remember 700 cc's of the liver should be kept at less than 15 gray, and your mean should be less than 13 gray. Moving on to GU, we're going to start by talking about seminoma because this is less commonly seen, and then we'll talk about bladder, prostate, and kidney. So as far as workup and staging of seminoma, these patients should have a full history and physical, and we do a scrotal examination and we palpate the abdomen for nodal disease. You can also palpate supraclavicular space to make sure they don't have METs. Labs, you want to get CBC, CMP, and the serum tumor markers are very important. AFP, beta HCG, and LDH. And these need to be done both before and after surgery because post-operatively, these serum tumor markers actually affect the staging. Now, as far as what to expect, if you have elevated AFP, that strongly suggests a non-seminomatous germ cell component because it's almost never elevated in a pure seminoma. And then an elevated beta HCG may be seen for seminoma, but if it's elevated a lot, it's more likely to be a non-seminomatous germ cell tumor. As far as imaging, you'll typically start by getting a bilateral scrotal Doppler ultrasound and you'll see a hypoechoic mass in the scrotum. You want to get a chest x-ray or a CT scan of the chest as well as a CT of the abdomen pelvis to evaluate for if there's nodal disease. And if they're symptomatic in any way or if there's a high beta HCG, also get brain imaging because these have a high risk of going to the brain if it's something like a choriocarcinoma. In order to get pathology, you are never, ever, ever going to do a biopsy. You will never stick any kind of needle or make any kind of incision inside the scrotum because there's a high risk of tumor seeding. So what you want to do is directly go to a radical inguinal orchiectomy with high ligation of the spermatic cord. Just learn that statement. Radical inguinal orchiectomy with high ligation of the spermatic cord. You will never poke a needle or make an incision directly into the scrotum. So directly go to a radical inguinal orchiectomy with high ligation of the spermatic cord. And then after they get surgery, you want to repeat those serum tumor markers, the AFP, LDH, and beta HCG, like we said, because it's used in staging. And always talk to these patients about fertility counseling, and you want to offer semen analysis and sperm banking prior to taking out their testes. So as far as seminoma staging, the only reason I mention this is because it can get very complicated if you look at the serum tumor markers and the T staging and everything. But the very basic principles of staging for seminoma is that number one, there is no stage 4. These have a very, very good prognosis, and there simply is no stage 4 in seminoma staging. If tumor is limited to the testes, so your board examiner will tell you if there's reedy testes invasion, if there's invasion of the spermatic cord, things like that. But if it's limited to the testes, it's always stage 1. If it's node positive, it's stage 2. And if it's metastatic, it's stage 3. So in order to understand how to manage seminoma, all you need to know is it limited to the testes or does it involve nodes? And then you'll know how to manage it. So stage 1 seminoma is seminoma that's limited to the testes, and we do inguinal orchiectomy with high ligation. And there's different options for management, but the preferred approach is actually active surveillance. And the reason we do active surveillance is because the vast majority of these will not recur. Only 10 to 15% of them will relapse. And if they relapse, then they will relapse most commonly in the para-aortic region. And at that point, they are managed the way that a stage 2 seminoma is managed. So just in case they press you on how you would manage a stage 1 seminoma, if for some reason the patient is not a good candidate for active surveillance, say they're non-compliant for some reason and you don't think that they're going to come in for repeat labs and imaging and exam every 6 months or so, then you can either manage them with radiation, where you give 20 gray and 10 fractions to a para-aortic strip, or you can manage them with carboplatin. The dose is AUC 7. So remember, for lung cancer, for esophageal cancer, when we do concurrent weekly carboplatin, the dose was AUC 2. For seminoma, if you're doing chemotherapy, you give a single dose of carboplatin, AUC 7. Okay? So stage 1 seminoma after surgery, we prefer to surveil them, do active surveillance, because only 10 to 15% of these patients will relapse. If they do, it's most likely within the first 3 years. But if they push you and they say the patient's not a good candidate for active surveillance, then you can do 20 gray and 10 fractions to a para-aortic strip, or you can give them a single dose of carboplatin, AUC 7. And then if they do relapse, then they are most likely going to come back as a stage 2 seminoma. And stage 2 seminomas, remember, are node positive. So the way that we manage these, we still need to get inguinal orchiectomy with high ligation, because remember, that's the first step to getting your pathology as well. And then the radiation management is doing dogleg radiation, where you kind of treat the para-aortic strip and then the ipsilateral external and internal iliac nodes. This is the preferred approach if you have nodes that are less than or equal to 3 centimeters in size. So you give a 20 gray to your dogleg field, and then you do 30 gray boost to any lymph nodes that are 2 centimeters or less. And if they're 2 to 3 centimeters, then you can do 36 gray boost. For patients that have nodes that are over 3 centimeters in size, we prefer chemotherapy, and you can do etoposide and cisplatin for 4 cycles, or bleomycin, etoposide, and cisplatin for 3 cycles. So it's either EP for 4 or BEP for 3. And then another option is to do retroperitoneal lymph node dissection. That's a more recent study that came out. I probably would not mention that on boards at all. Most likely if they're giving you a stage 2 seminoma, they want you to do dogleg radiation with a boost to the lymph nodes. So you should be able to describe your radiation fields for seminoma. And if you're doing stage 1, you treat 20 gray and 10 fractions to the para-aortic strip. And the field for the para-aortic strip, if you're doing 3D planning, goes from the bottom of T11 to the bottom of L5. And you want a 10 centimeter wide para-aortic strip that encompasses the transverse processes of your vertebral bodies. And important organ at risk dose constraint is the kidneys. So you want to keep your D50% to the kidney less than 8 gray. You want to keep your mean less than 3 gray. And if there's only one kidney, then D15 less than 20 gray. But remember, D50% less than 8 gray, mean less than 3 gray for the kidney, and you use a clamshell to protect the contralateral testes. If you're doing stage 2, then you're doing a dog leg field. And what does that mean? That means that you're covering the para-aortic strip, but also the ipsilateral iliac lymph nodes. So your field starts at the bottom of T11 and it goes down to the bottom of L5. But then starting at L5, you cover the ipsilateral dog leg field. So it looks like a dog sticking its leg out to urinate. So starting at L5 on the ipsilateral side, you go from the bottom of L5 to the lateral aspect of your acetabulum. And then on the kind of contralateral side, you go from the bottom of L5 to your ipsilateral obturator foramen. So you're then covering a dog leg field. And you take that whole field to 20 gray, and then you boost your involved nodes to 30 to 36 gray. So if it's 1 to 2 centimeters in size, you do 30 gray. If it's 2 to 3 centimeters in size, you boost to 36 gray. And again, don't forget your key organ at risk dose constraint, which is the kidney. So D50% less than 8 gray for the kidney, and your mean is less than 3 gray. Now, there is a paper on 3D planning with contouring these lymph node volumes. And this is a good paper to know to reference because in actual practice, you might want to have, a target volume contoured. And if they press you to describe that, I think it's even more complicated than just memorizing the fields. But you basically contour the IVC and the aorta from below the top of the kidneys to the point where those blood vessels end for your stage 1. And it's a 1.2 centimeter expansion on the IVC, 1.9 centimeter expansion on the aorta, cropped out of bone and bowel. For stage 2, you also put a 1.2 centimeter expansion on your iliac vessels, cropped out of bone and bowel. So I would just understand which nodes you're covering. But I think it's going to be more important to describe these kind of 2D fields for seminoma versus knowing how to contour. Let's move on to bladder cancer. And remember, for non-muscle invasive bladder cancer, these patients can typically just be managed with a TURBT and then subsequent intravesical chemotherapy. Radiation is an option for managing muscle invasive bladder cancer. So as far as workup, these patients do need cystoscopy with TURBT. That's how we get pathology. They need CT urography, so that's a contrast CT. And they should also have either a CT chest or a PET CT to evaluate for distant metastasis. So for muscle invasive bladder cancer, the first question we have to ask is, are they a surgical candidate? And if they are, then the standard is typically cystectomy with perioperative chemoimmunotherapy. If they do not want surgery or they're not a surgical candidate, then they may be a candidate for bladder preservation using maximal safe TURBT followed by chemoradiation. Now, who are candidates for bladder preservation? So if a patient is a candidate for surgery, but they decline surgery, these criteria are really important when making a recommendation for chemoradiation. If a patient simply can't get surgery because of other comorbidities, then of course we do the best we can with chemoradiation. But if patients have a really solid chance at cure with surgery and they're declining surgery, then they need to meet these criteria for bladder preservation. So what are they? They need to have a unifocal tumor that's less than 5 centimeters after complete TURBT and no associated carcinoma in situ. They should be T2 to T3, select T4A is okay, and they should be clinically node negative. They should have adequate bladder function, and they should not have hydronephrosis. If they have unilateral hydronephrosis, it's okay for them to get a ureteral stent first, but ideally no hydronephrosis. You don't want them to have inflammatory bowel disease or prior pelvic radiation, some contraindication to radiation basically. And they should be compliant with surveillance because they're going to need regular cystoscopies moving forward. So what do we do as far as the radiation and the concurrent chemo? There's options for dose fractionation for bladder cancer. You can do 64 gray and 32 fractions conventional fractionation, or you can do 55 gray and 20 fractions, which is moderately hypofractionated. The concurrent chemotherapy is 5-FU mitomycin C or you can do concurrent cisplatin or gemcitabine. I just remember 5-FU mitomycin C. The dosing is a little bit different than anal cancer dosing. It's 500 milligrams per meter squared 5-FU given at week 1 and week 4. And then it's just a single dose of mitomycin C, 12 milligram per meter squared given on day 1. Now, there's data that it doesn't make a difference if you treat the whole bladder or the partial bladder and then just boost the involved tumor to the full dose. So either way, the whole bladder is going to get some dose of radiation, and you can either take the full bladder to the full dose or you can boost the tumor. It's easier to meet dose constraints, though, if you obviously just boost the tumor to the full dose. Nodal coverage is very controversial. Usually we don't cover elective nodes, but if patients are very high risk for whatever reason, or if they have involved nodes, you can treat. So if they're just high risk and you're covering electively, the typical volume that we do is the quote unquote small pelvis, which is just external and internal iliac, obturator, and perivesical lymph nodes. If they're node positive, you can expand that to cover the common iliacs as well. In this table, I have some dose constraints you can know for the 55 gray in 20 fraction regimen. So the dose to the rectum, you want your V20 less than 50%, V40 less than 35%, and V50 less than 10%. And then small bowel, you want V55 less than 5 cc's, and femoral head, you want your max of 41 gray, max less than 41 gray. So these are just easy dose constraints for the 55 and 20. If you're doing conventional fractionation, then you can kind of reference the GI or even honestly prostate dose constraints that we use for your bowel constraints. I think most people know prostate cancer very, very well because it is so common. So I'm not going to belabor the risk grouping. Take a minute to review what makes you low versus intermediate versus high risk. And as far as management options, low risk patients, you can offer active surveillance or radiation or surgery. Once they're intermediate risk, we typically think about doing some type of definitive treatment. Favorable intermediate risk can be managed with surgery versus radiation alone. If they're unfavorable intermediate risk, their options are surgery or radiation with short-term androgen deprivation therapy. If they are high risk, then we do radiation and long-term androgen deprivation therapy. And remember the patients that meet the STAMPEDE criteria, so if they have node-positive disease or 2 or more of the following risk factors, so T3 to T4 disease, a Gleason score of 8 or higher, or a PSA of 40 or higher, then we add abiraterone to the long-term ADT. Here are some common regimens that we might use for treating prostate cancer and associated dose constraints. So a commonly used moderately hypofractionated regimen is 70 gray and 28 fractions. And if you decide to treat pelvic lymph nodes, you can treat 45 gray and 25 fractions to the pelvis, although pelvic lymph node radiation is extremely controversial for prostate cancer. For patients that have intermediate risk disease, the proximal 1 centimeter of seminal vesicles should be covered as well, and you can take that to a lower dose of 56 gray. So for 70 gray and 28 fractions, some easy dose constraints to remember. Keep your bladder and rectum V70 gray less than 10% and V50 gray less than 25%. Okay, 70 less than 10%, 50 less than 25%. Small bowel, you can always use that V45 gray less than 150 to 195 cc's. Make it easy to memorize. I think these are the most important constraints for prostate, moderately hypofractionated. For prostate SBRT, if they push you to do SBRT, 36.25 gray in 5 fractions is the commonly used dose based on the PACE trials. And with this, we take the PTV to 36.25 gray in 5 fractions, but we use 40 gray to the CTV. And our expansions are 5 millimeters everywhere, except for posteriorly towards the rectum, we only do 3 millimeters. And similar to the previous regimen we discussed, if patients have intermediate risk disease, you can include the proximal 1 centimeters of the seminal vesicles in your CTV. Here are some simplified prostate SBRT dose constraints that are easy to remember. So you want your max dose to the rectum, bladder, and urethra to be no more than 38 gray. And you want your D50% to the rectum and bladder to be less than 18 gray. Okay, so for prostate SBRT, max of 38 gray and D50% less than 18 gray for the rectum and bladder. Purely for reference, if they push us for brachytherapy for prostate, here is a slide on LDR brachytherapy. I would just pick a source that you're going to use, know its half-life and average energy, and the dose that you need to give, whether you're giving monotherapy or brachytherapy boost for patients with higher risk disease. Memorize some of these constraints and your pre-plan versus post-plan coverage goals, and then understand who is a good candidate for brachytherapy. And really, patients that have very large prostate volume or patients that have significant lower urinary tract symptoms, especially obstructive symptoms, these are poor candidates for brachytherapy boost. And similarly, here is a slide on HDR brachy for reference. If they push you for doing brachytherapy, I would just stick with whatever modality is used at your institution and whatever you're used to. And if you haven't done brachytherapy for prostate, I would just be honest about that. You may be asked about indications for post-operative prostate cancer. And remember, after surgery, even if patients have a positive margin or if they have certain risk factors, the recommendation is to monitor their post-op PSA and only treat with salvage radiotherapy if they have a true biochemical recurrence and their PSA either never becomes undetectable or it starts to become detectable. If PSA starts to become detectable, you can consider getting a PSMA PET scan, especially if patients have a PSA of over 0.2. If the PSA is less than that, then the PSMA PET scan probably won't be helpful. You want to consider doing postoperative radiation to the prostate fossa. So you'll always do postoperative radiation to the prostate fossa. You will consider adding short-term androgen deprivation therapy as well as pelvic lymph node radiation if PSA is over 0.35. And then if they have a PSA that's much higher of above 6, you might consider adding long-term ADT. In practice, a lot of folks may be using genomic risk scores such as the Decipher score to help make some of these decisions because it's not well understood. But I think on boards, it would be safe to add short-term ADT and pelvic lymph node treatment for a PSA of over 0.35. And then if it's over 6, over 0.6, you would add long-term ADT. And then as far as the postoperative dosing, so 64.8 gray and 36 fractions comes from the SPORT trial, and you can just do that and do 45 gray and 25 fractions to the pelvis. If they have gross residual disease in the prostate, you want to boost that to a higher dose of 70 to 74 gray, because remember, this is now conventional fractionation. And then if they have residual nodes, you want to boost those to at least 55 to 60 gray if possible. And then these are some postoperative prostate radiation constraints from the 0534 SPORT trial. So rectum V65 gray less than 35%, V40 gray less than 55%, bladder minus CTV 65 less than 50%, 40 less than 70%. Small bowel, the same dose I always know for small bladder, which is 45 gray less than 150 cc's. And then femoral heads V50 less than 10%. Just in case kidney SBRT shows up on the exam, keep in mind that renal cancer is typically managed with nephrectomy, but early stage renal cancer can be managed with kidney SBRT as well. So for simulation, you would consider keeping these patients NPO, you would do a motion study, consider DIBH. And again, it's not on the slide, but IV contrast would be very, very helpful. If you don't have IV contrast available, you need to fuse a contrast enhanced image so you can see the tumor. The dose is 48 gray in 3 fractions, and you typically just treat the GTV with 3 to 5 millimeter margins for PTV. And constraints, you want to keep your small and large bowel max dose less than 25 gray. Your stomach, duodenum, spinal cord maxes less than 22 gray. So duodenum is smaller max than the small and large bowel. The ipsilateral uninvolved kidney as low as reasonably allowable. The V10 ideally would be less than 33%. And for the contralateral kidney, you want to keep your mean less than 8 to 10 gray. Last two sections, we have GYN followed by breast. So as we know, most patients with endometrial cancer undergo upfront surgical staging with a total hysterectomy, BSO, and sentinel lymph node biopsy. They're typically going to present with abnormal bleeding, often postmenopausal bleeding that prompts a transvaginal ultrasound that reveals a thickened endometrial stripe, so anything greater than 4 millimeters in thickness is thickened. That prompts a biopsy, and then we get a CT of the chest to make sure they don't have any metastatic disease. And then they go for surgical staging with total hysterectomy, BSO, and sentinel lymph node biopsy. And remember, for endometrial cancer, you can just do a total hysterectomy. If they have cervical involvement or if they have cervical cancer, you need to do a modified radical or a radical hysterectomy. So they go for surgical staging, and if they are early stage disease, that means the disease is limited to the uterus and cervix. And what we really care about is how deeply invasive it is into the myometrium. So I just use the FIGO 2017 staging system because that is what our management paradigm is based on. So 1A is less than 50% myometrial invasion, 1B is greater than 50% myometrial invasion. If they have stage 1A, grade 1 to 2 disease, it's fair to observe them, unless they have risk factors such as age of over 60 or LVSI, in which case that might push you into doing vaginal brachytherapy. If they have stage 1A disease and they are grade 3, or 1B disease and they're grade 1 to 2, then you want to do vaginal brachytherapy. And again, if they have more risk factors, that might push you into the next category of doing EBRT plus vaginal brachytherapy. So if they have stage 1B grade 3 disease, stage 2 disease where they have cervical involvement, or if they have substantial LVSI, so that is defined as having more than 4 foci of LVSI, then these patients should be getting 45 gray and 25 fractions external beam radiation to the pelvis, followed by adjuvant vaginal brachytherapy. And then finally, for patients that have high-risk histologies, so for example, if they have clear cell or serous carcinoma, then you need to think about adding chemotherapy. Or if they have carcinosarcoma also, you do chemotherapy followed by radiation, and that can be external beam with or without vaginal brachytherapy. Stage 1A clear cell it's okay to just do vaginal brachytherapy alone with chemoctherapy, but otherwise all these patients need both the external beam and the vaginal brachytherapy. Now, the vaginal brachytherapy doses are listed at the top of the slide. So if you're just doing vaginal brachytherapy alone, you can do 21 gray and 3 fractions or 30 gray and 5 fractions. We often prescribe this either to the surface or to the depth, 5 millimeters depth usually. And then if they're getting upfront external beam, the vaginal brachy dose is lower. So it can be 10 gray and 2 fractions or 15 gray and 3 fractions. Then if we have more advanced endometrial cancer, so disease involving the vagina, adnexa, parametria, or lymph nodes, that pushes you into the stage 3 to 4A category. And for those patients, they do benefit from chemotherapy, and oftentimes we do a sequential approach where they get chemotherapy first, so carbotaxol for 6 cycles, followed by adjuvant external beam radiation with or without a vaginal brachytherapy boost. And it can get more complicated than that. There's possible to have endometrial cancer patients that are not candidates for surgery because of other medical comorbidities where we have to do definitive radiation. But I think everything I have on this slide should hopefully be enough to get us through boards. That brings us to cervical cancer. And remember, cervical cancer is most often squamous cell histology, although you can have adenocarcinoma histology also. And it's very, very, very important to get a PET-CT and an MRI for staging. The MRI is to assess the local extent of disease, and the PET-CT is to assess for nodal and distant metastases. So certain early stage cervical cancer patients can get surgery up front, and that's done with a radical hysterectomy and sentinel lymph node sampling. And indications for postoperative radiation after a radical hysterectomy are based on the SEDLIS criteria. So tumor size of over 4 centimeters, deep stromal invasion, or LVSI. If they get surgery and they have size over 4 centimeters, deep stromal invasion, or LVSI, they should be getting adjuvant radiation. And if they have positive nodes, positive margins, or positive parametria, those fall under the Peters criteria, which are indications to not only do adjuvant radiation, but also add concurrent chemotherapy with that. So SEDLIS criteria is adjuvant radiation, and that's tumor size over 4 centimeters, deep stromal invasion, LVSI. Peters criteria is indications for adjuvant chemoradiation, and that's positive nodes, positive margin, positive parametria. And the dose is, again, 45 gray and 25 fractions. It's always 45 gray and 25 fractions for GYN. As far as the definitive management of cervical cancer, up front, if you know that patients are going to have some of these criteria that would require double or triple therapy with surgery and radiation and possibly chemo also, then the preference is to actually just do chemoradiation. And when we do definitive chemoradiation, and I think most cervical cancer patients, I mean, I know I'm biased because that's what I see, but a lot of times these patients present with very, very advanced disease because these are often patients that have not been getting screening and it's just gotten very advanced. So the management of this is chemoradiation, 45 gray and 25 fractions external beam, and then you can boost involved lymph nodes to 55 to 57.5 gray as a simultaneous integrated boost. And we do concurrent weekly cisplatin, 40 milligram per meter squared. And following that external beam radiation phase, they then get a brachytherapy boost, and the dose can be 28 gray in 4 fractions or 30 gray in 5 fractions, and we boost the high-risk CTV. The goal coverage of the high-risk CTV is an EQD2 sum, so that includes your external beam dose, of 85 to 90 gray. You may be asked to define the HRCTV, and you're basically contouring any gross residual tumor at the time of brachytherapy, the entire cervix, and also any residual areas of parametrial or paracervical extension. As far as dose constraints, the top table on the right-hand side has the dose constraints for the EBRT portion, and these are very, very similar to other, even in the GI section, things that we talked about. So those are there for reference. The most important dose constraints to remember from brachytherapy perspective are the dose to 2 cc's that we look for the bladder, rectum, and sigmoid and small bowel. So the bladder dose to 2 cc's should be less than 80 gray, ideally. And then everything else, the dose to 2 cc's should be less than 65 gray. I think these are the easiest numbers to remember. In practice, if you're having difficulty, there's a little bit of leeway and you can go, 65 to 70 gray, or you can do 80 to 85 gray for the bladder. But on boards, I would just say bladder dose to 2 cc's less than 80 gray. Everything else, including the rectum, less than 65 gray. The last slide that I have is for vulvar cancer. And vulvar cancer is fairly rare, but remember when we stage vulvar cancer, we want to get a PET CT. Early stage vulvar cancer can be a candidate for resection, and we do wide local excision for stage 1A vulvar cancer. For more advanced vulvar cancer, they need a radical vulvectomy and inguinal sentinel lymph node biopsy with completion dissection for patients that have macroscopic lymphadenopathy on sentinel lymph node biopsy. So if patients do get surgery, the indications for radiation to the vulva are if they have close margins defined as less than 8 millimeters, or if they have additional risk factors such as LVSI, a depth of invasion greater than 5 millimeters, if their tumor size is very large, or if they have diffuse or spray histology. Indications to treat the inguinal or pelvic lymph nodes is if they have 2 or more positive nodes, if they have extracapsular extension. You can also consider if they have 1 positive nodes and a small dissection where they had less than 12 lymph nodes dissected. And there's no real clear indications described for concurrent chemotherapy, but I would just keep these in mind for indications for postoperative vulvar cancer. Many times in practice, what we end up seeing is patients that have unresectable vulvar cancer, and these patients we often do treat with concurrent chemoradiotherapy. And in the smaller table on the right-hand side, I have the radiation dosing that we think about for vulvar cancer. So the pelvic nodes, and keep in mind that in vulvar cancer staging, if you have pelvic lymph nodes, that's actually considered stage 4. It's still stage 3 if you only have inguinal lymph node involvement, but once you have pelvic lymph node involvement, it's considered stage 4. So you treat your elective pelvic volume to 45 gray and 25 fractions, but you treat your inguinal nodes to 50 gray usually. Any clinically involved lymph nodes, you want to boost them to 55 to 58 gray. And if they're bulky, then you can even do additional sequential boost. And then your vulvar GTV, if you're doing it preoperatively, then you can think about just going to 60 gray. But if not, you want to go higher to 66 to 68 gray. So vulvar cancer can be very challenging to treat, but I think these are some basic principles that should help you hopefully talk through a case. And in GU section, I did not talk about penile cancer. I personally have never seen a penile cancer case or managed it. But from what I understand, the management principles for penile cancer are very, very similar to vulvar cancer. And that brings us to our final section, which is breast cancer. So, unique aspects of workup for breast cancer. Obviously in history, you inquire about whether they've palpated anything, if they have any nipple discharge, if they have any pain associated, family history, history of radiation, history of exposure to hormone therapy, genetic testing as well. And then exam, you do your breast, axillary, supraclavicular lymph node exam, and also examine the skin of the breast. For imaging, keep in mind that most patients are going to come in with a screen-detected abnormality on a screening mammogram. But if a patient has a palpable mass, then they should go straight to a diagnostic mammogram and ultrasound. So either patients will have screening mammogram that prompts a diagnostic mammogram and ultrasound, or if they have something palpable, they go straight to the diagnostic mammogram. And the benefit of the diagnostic mammogram is that it offers additional views. So you can get spot compression that helps you differentiate fibroglandular breast tissue versus a mass. It also offers magnification views that can basically help you zoom in on abnormalities. MRIs are often obtained widely, and this is very institution dependent. But if you go by the textbook, you should really be obtaining MRIs, especially if patients have lobular histology, because lobular histology can be occult on mammogram, or if they have some other risk factor like a prior history of radiation. But what you'll see is oftentimes patients that are getting upfront neoadjuvant chemotherapy, they'll just get an MRI so that we can have an easy way of monitoring their clinical response. The systemic staging guidelines for breast cancer are, if you look at the guidelines, they often just say as clinically indicated, which I think is kind of confusing. But basically, any patients that have any symptoms like bone pain, headache, anything that you're worried about, that should prompt imaging. So bone scan, PET CT, or CT chest, abdomen, pelvis, and quote unquote, this should be done as clinically indicated. If patients are getting neoadjuvant chemotherapy, or they have T2 or higher or node positive disease especially, I think at minimum it makes sense to get a bone scan, if not more comprehensive imaging with either a PET CT and or a CT chest, abdomen, pelvis. So especially if they're getting neoadjuvant chemo, get systemic imaging. Especially if they're node positive, also think about getting systemic imaging. For biopsy, you want to get a core needle biopsy again, okay? So this can be done ultrasound guided or stereotactic. Oftentimes with DCIS, these are just going to be calcifications on a mammogram, and it's not able to be visualized on ultrasound, so that's when you need stereotactic biopsy. But breast masses, which are breast cancer usually, these are often detectable on ultrasound. So if you can see it easily on an ultrasound, that's the easier way to get the biopsy. If you can't see it on ultrasound, which is often the case for the calcifications for DCIS, then you get stereotactic. And remember, it's a core needle biopsy, and you place a clip at the time of biopsy so that when you go for surgery, you can confirm that the clip came out. And any suspicious axillary lymph nodes that are seen on ultrasound should also be biopsied. Now, the primary management for breast cancer is with surgery. We do a lumpectomy with mastectomy, a lumpectomy usually, or a mastectomy if indicated. And then we also get sentinel lymph node biopsy always. Or we get axillary lymph node dissection if patients have clinically node positive disease. Now, there's a subgroup of patients that, based on choosing wisely criteria, can omit sentinel lymph node biopsy. And these are patients with low risk early stage disease that are 70 and older. So think about like your hormone positive patients that are over age 70 that have early stage disease. They don't have to get sentinel lymph node biopsy. But I think on boards, it's fair to just say lumpectomy with sentinel lymph node biopsy, or if they tell you the patient's getting a mastectomy. And then if they have clinically node positive disease, they should be getting an axillary lymph node dissection. And then everything is tailored, right? So systemic therapy can be given up front or adjuvant, and radiotherapy is always given adjuvant. So let's talk about some considerations around systemic therapy and radiation. So here's a couple tables where I've tried to sum up systemic therapy for breast cancer, okay? So the first half, I talk about indications for neoadjuvant chemotherapy and how we tailor their adjuvant systemic therapy based on the response to neoadjuvant chemotherapy. So for all breast cancer, I think it's easiest to just divide into three groups, right? You have your hormone positive, HER2 negative, you have HER2 positive, and then you have triple negative. So which patients should be getting neoadjuvant chemo? Within hormone positive and HER2 negative, remember this is kind of a more favorable histology. So we really think about neoadjuvant chemo for patients that are premenopausal with any number of nodes positive, or patients that are postmenopausal with 4 or more nodes positive. Within HER2 and triple negative, the indications are broader because these are higher risk histologies. So if the tumor's over 2 centimeters, or if they have node positive disease, you can offer neoadjuvant chemo for HER2 positive and triple negative breast cancer. And one of the advantages of neoadjuvant chemo is that you can get some shrinkage of the tumor and downstaging, and this may allow for some patients that may not have been eligible for breast conserving surgery up front to then undergo a lumpectomy instead of a mastectomy. So that's an advantage of neoadjuvant chemo. The other advantage is that these are, more aggressive, locally advanced cancers. So giving neoadjuvant chemo and then restaging right before surgery, it helps you kind of biologically identify patients that are responding favorably versus if a patient develops metastatic disease on the neoadjuvant chemo, then you know that histologically they had very high risk disease. So what are the regimens for neoadjuvant chemo? For HER2 positive, for hormone positive and HER2 negative, there's no targetable therapy, right? These patients don't really respond well to upfront endocrine therapy. They're not going to get much shrinkage. So we just give them chemotherapy, and the regimen is often ACT. For HER2 positive, we have targeted therapy with Herceptin, so the regimen is TCHP. And for triple negative breast cancer, we have the Keynote 522 trial that showed a benefit to TCAC chemo with pembrolizumab, so concurrent and maintenance pembrolizumab. So these are the neoadjuvant chemo regimens you should know. Hormone positive, HER2 negative, ACT, HER2 positive, TCHP, and triple negative, it's TCAC with pembro. And then we need to know how many of these patients are expected to have a pathologic complete response. So the most likely patients to have a pathologic complete response are the HER2 positive and the triple negative breast cancer patients, and it can be 65% or higher rates of PCR for those histologies. The hormone positive HER2 negative, unfortunately, don't always have good PCR rates. It's much lower, on the order of 25% or so. So if patients do have a PCR, for the hormone positive HER2 negative, you can just do endocrine therapy. For HER2 positive, you do HP maintenance therapy. And for triple negative, you do pembrolizumab maintenance therapy. If they have residual disease, though, you need to give them something more because they didn't respond well to the upfront chemo. So for hormone positive, HER2 negative, it's a CDK4 or 6 inhibitor, such as abemaciclib or ribociclib, and endocrine therapy. For HER2 positive, we give them TDM1. And for triple negative, we give them Xeloda with their maintenance pembrolizumab. Then we have our patients that did not get any neoadjuvant chemotherapy, and we need to understand what the indications for adjuvant systemic therapy are in these patients. So for our hormone positive, HER2 negative patients, after surgery, all patients are going to get endocrine therapy for at least 5 years, and all these patients should get something called an oncotype score, which is a genomic risk score that helps us decide if they need chemo or not. If their score is over 25 and they're postmenopausal, or if it's over 16 and they're premenopausal, this is the group where they should be considering chemotherapy. So in the Taylor RX trial, oncotype score of over 25 always got chemotherapy. And then on subset analysis for premenopausal patients, scores between 16 and 25 were kind of higher risk, so they should at least have a discussion of chemotherapy. But oncotype score is what determines if you get chemo, if you're hormone positive, HER2 negative. So as far as what the regimen for chemotherapy is, you can just do TC if you're node negative, or you can do ACT if you're node positive. It can get a bit confusing because premenopausal, if they're node positive, are usually offered chemotherapy. But for postmenopausal, as long as they have 1 to 3 positive nodes, we still go off the oncotype score to decide if they get chemo. For stage 2 to 3 patients that are not getting chemotherapy, you can do a CDK4/6 inhibitor such as abemaciclib or ribociclib as well. So that's something that you might see where they get hormone therapy and then a CDK4/6 inhibitor if their oncotype is low. And then the hormone therapy that we do is anastrozole if you're postmenopausal or tamoxifen if you're premenopausal. For HER2 positive and triple negative breast cancer, remember, these are more aggressive histologic subtypes, so our indications for adjuvant therapy are broader. So if you're HER2 positive, there's an argument for adjuvant systemic therapy, which is HER2-directed therapy with chemo, if you're over 5 to 10 millimeters, and same thing for triple negative, if the tumor size is over 5 to 10 millimeters. I have seen sometimes in like elderly, 80-plus-year-old women, when they have like a 6 millimeter HER2 positive tumor, their oncologist will have a discussion with them, and sometimes they'll elect to decline, chemo and HER2-directed therapy, which I think is fine. But for boards, know that if it's over 5 to 10 millimeters and it's HER2 positive or triple negative, they should be having a conversation about adjuvant therapy. So for HER2 positive disease, the adjuvant regimen is either just Taxol and Herceptin if you're stage 1, so less treatment, or if you're more than stage 1, then TCHP. And for triple negative breast cancer, they can just get ACT. And then if they met those Keynote 522 criteria where they had over 2 centimeter tumor or they had node positive disease, then they can get TCAC and Pembro. Here are some common indications for radiotherapy. And most simply, what I think about is if you're getting a lumpectomy, you're almost always going to get adjuvant radiation. If you have a mastectomy, then if you have stage 3 or higher disease, or if you have node positive disease, you're almost always going to get adjuvant radiation. So let's just go through some common different questions that we might encounter and how radiation comes into play. So are there situations where we can omit adjuvant radiation after a lumpectomy? Yes, we can omit radiation for patients that are older with hormone positive HER2 negative disease. So patients that are 65 to 70 years old, hormone positive HER2 negative disease. We have data based on PRIME2 and CALGB9343 studies, and we're expanding some of those criteria too with ongoing studies to see if maybe even younger patients that have favorable hormone positive early stage disease can omit radiation. The key thing that we know right now is that for these patients, if they get lumpectomy and they just get endocrine therapy alone, their local recurrence risk is about 10%. If we give them adjuvant radiation, we drive it down to about 1%. So they are candidates for omission, but these patients can often get accelerated partial breast treatment as well, and they can then have a really low chance of local recurrence. What are indications to treat your regional lymph nodes? And I think for board exams, if you're lymph node positive, then you treat the regional lymph nodes. There is the NSABP B51 study that looks at patients with upfront node positive disease that was, low nodal burden that had a complete response in the nodes at the time of surgery. I still think despite that trial, you can make an argument to treat, especially for hormone positive patients where we know that we need much longer term follow-up than what we have from NSABP B51. So for the boards, if you just remember if they're node positive, you probably should be treating their regional lymph nodes. Indications for post-mastectomy radiation, again, if they have stage 3 or higher disease, if they have node positive disease, or if they have a positive margin that's positive for invasive cancer. DCIS, if they happen to get a mastectomy and then they have a positive margin for DCIS, that's usually okay to observe based on retrospective data, unless they have like a diffuse positive margin. But if they have invasive cancer and a positive margin, you do need to treat that. And then what are indications for treating an axilla that's dissected? Like a lot of times they'll just get sentinel lymph node biopsy and then we're doing regional lymph node radiation, kind of based on the Amorose trial. But some patients that have a dissected axilla need axillary radiation. So some of these indications are, number 1, if they have an inadequate dissection, so we removed less than 10 lymph nodes. Number 2, if they have fixed or matted lymph nodes or extensive extracapsular extension, that makes you concerned that there's essentially a positive margin for lymph nodes left behind. And then number 3, if they have over 50% of their lymph nodes positive, that's another risk factor. And then finally, what are indications to boost after a lumpectomy? So the easiest indications to remember and the most commonly cited, I think, are high grade and age less than 50. So if they have grade 3 disease or if they're younger than 50 years old, we're always going to be boosting. And then also in practice, if they have higher risk histology, like triple negative, or if they have other risk features that make you worried, like LVSI, or, oftentimes if they have node positive disease, even I think about boosting. Any risk factors really is when you boost, but the clearest indications are high grade and age less than 50. We mentioned accelerated partial breast irradiation earlier, and if you're going to offer APBI on boards, I would lean towards only offering APBI for patients that meet the suitable criteria. In practice, I often do APBI even in that cautionary, but I think for boards, it's just safer to stick to the suitable criteria. So if they have grade 1 to 2 disease, if they're estrogen positive, if they're over 40 years old and their tumor size is less than or equal to 2 centimeters, that is when you can do APBI for both invasive and DCIS. Unsuitable criteria are if they have positive lymph nodes, positive margin, known BRCA mutation, and if they're less than 40 years old. So definitely know who cannot get APBI. And if you're going to answer on boards, I would kind of stick to answering APBI for patients that fully meet those suitable criteria. For everyone else, you're never going to be wrong to just give whole breast radiation, plus or minus boost. Here are some common radiation dose regimens. I would just stick to what you use in practice, but just for reference, we'll start with APBI since we just talked about it. So for APBI, the regimen I use is 30 gray and 5 fractions. It can be given daily or every other day. And you want to keep your volume receiving 105% at 0. So you want your V105 to be 0 for APBI. And the most important margin is the dose to the uninvolved breast. So that's your normal breast minus your target volume. And you want your V50% to be less than 50%, right? So the volume receiving 15 gray should be less than 50% for the uninvolved breast. Contralateral breast, you want to keep it less than 1 to 2 gray. The ipsilateral lung, V10 less than 20%. Contralateral lung, V5 less than 10%. And heart, V3 less than 10%. The only other dose constraints that I'm probably going to be memorizing for boards are for whole breast radiation. And the regimen I use for that is the UK Start B regimen of 40 gray and 15 fractions. And important constraints from here, As far as your hot spots, so you want your V105 less than 10%, 107 less than 5%, and 110% to be 0. And then ipsilateral lung, you want your V20 gray to be less than 10 to 20%. You can accept up to 35%, but remember this is breast, so hopefully you're not going as high as with lung. Heart, you want your mean less than 2 gray. Contralateral lung, you want your V5 gray less than 5 to 10%. Contralateral breast, you want V3 less than 5%. And I think these are the most important constraints that we should know for breast radiation. The final 2 slides that I have for this talk are radiation fields and kind of planning considerations for breast. So when you describe your breast radiation fields, you should be able to state your standard field borders, right? So for normal breast radiation, we treat superiorly to the inferior aspect of the clavicle head, so bottom of the clavicular head, and we go down 1 to 2 centimeters below the inframammary fold. Our medial border is midline, center of the sternum, and our lateral border is the mid-axillary line. And these are the borders that we use to set up our tangential fields. And when we set up our tangential fields, the beam arrangement is opposed tangents that are arranged so that posteriorly we have non-diverging fields, and we have about 1 centimeter of flash anteriorly. Now, what if you are treating supraclavicular nodes? The borders of the supraclavicular field go from the bottom of the cricoid cartilage to the bottom of the clavicular head. Medially, we go to the lateral edge of the vertebral pedicles, and laterally, we go to the coracoid process and we block the humeral head. Now, they might ask you where hot spots fall when you're doing opposed tangents, and they typically fall within the medial and the lateral aspects of the breast, so the areas where the tissue is thinner. So kind of like the anterior portion of the breast and then the lateral aspects of the breast and the medial. And then also, they might ask you, how do you minimize that? So we minimize the hot spots by using wedges, and you can also use a field-in-field technique to mitigate hot spots. And then they might ask you, what are some techniques for giving a tumor bed boost? And this can be done using electrons, or we can do mini tangents, where we do mini tangents, and sometimes you can even add a third arc as like a 3-field and give a small arc over the breast. And then finally, you might need to discuss dual versus mono isocentric technique for supraclavicular field radiation. So normally what we try to do is a mono isocentric technique when we're radiating the lymph nodes, right? So we try to keep iso at the bottom of the clavicle head. For our tangents, we use a half beam block superiorly so that there's no divergence into the supraclavicular field. And then we have a supraclavicular field that also has a half beam block, so there's no divergence below. Sometimes, however, we have a very long torso, and usually we're able to use the half beam block technique if our region of interest is up to 20 centimeters long. But if it's longer than that, then we're not able to do the half beam block, and half beam block tangents would not cover the whole breast because you have this long torso. So then what you need to do is to do a dual isocenter where you're using the entire field allowance for your tangents, and then but then the problem with that is there's no half beam block, so there's divergence up into the supraclavicular field. So how do we handle that problem? So it's kind of similar to what we think about for craniospinal irradiation. Remember, craniospinal irradiation, we have to match the divergence of the brain and the spine fields. So we have to kick the couch toward the head of the gantry for craniospinal irradiation. For breast, we actually have to kick the couch away from the gantry. And that allows us to eliminate the divergence of the superior tangent field into our supraclavicular field. Okay, so for breast, you kick the couch away from the gantry. For CSI, you kick the couch toward the gantry. And one of my former co-residents had a good mnemonic for that. Kids that are normally getting CSI, you pull them toward you and do a hug. So that's toward the gantry. Adult breast patients, you push them away from you. So you kick the couch away from the gantry. Okay, so you have to kick the couch away from the gantry and breast so that the divergence of that tangent field superiorly kind of matches your supraclavicular field. The other thing that you have to do is that you have to rotate the collimator for the tangents so that you match the angle of the chest wall. And then you can still use the half beam block for the supraclavicular fields so that there's no divergence inferiorly into your tangent fields. So I know that was a lot and very technical and kind of physics heavy, but I think that if breast section becomes hard, then this is the stuff that they will ask us about planning, describing your breast fields and mono versus dual isocenter. So hopefully this review of that was helpful. And that's all I have. I know that this was a crazy long video, but one thing I've learned from taking exams, and we've all taken a lot of exams at this point, we all know a lot of information, and in the deep recesses of our brain, it is stored somewhere in there. I think the biggest issue that happens, especially for me on exams, is just being able to recall that quickly and in this case cleverly, because we have to be able to verbalize it. I think what helps me a lot on exams is not necessarily chasing into areas that I don't know, but rather just refreshing and keeping at the top of mind the things that I do know. Because usually in medicine, you're never going to know everything, but the things that you do know are enough to figure out and intelligently make educated guesses on the things that you don't know. And for oral board exams, if there is something that you truly, truly do not know, I think it's fair to just be honest and say that you don't know it. So the purpose of this video, hopefully, was to just give kind of a bird's eye view of each disease site, kind of refresh all of these important categories that we need to know, and just bring back a lot of this information that we may not have thought about in a while to the top of our mind. And if you have it at the top of your mind, hopefully it'll be easily accessible and something that you can verbalize on the day of oral boards. So thank you so much if you're still listening to this 3+ hour talk. Again, as I said in the beginning, my hope is that, I know this is not a comprehensive video. There's other stuff in Rad Onc that I did not go over. It's possible that I shared certain dose fractionation regimens that are different than what you're used to using, and that's fine. There's a lot of variation. But I hope that I've provided some correct ways to answer things and reviewed everything at least at a surface level so that when you do get to oral boards, you can easily recall this information. So thank you so much. Again, if you're still listening, really, really appreciate it. Thanks for your time and attention, and good luck with studying and with the exam.